Okay, guys, welcome back for this second part discussion of ATP anatomy. So, in the first part, we discussed the head, neck, and face topics which were asked in the recent time. So, in this session, guys, let's talk about the neuroanatomy. Some of the important images of the neuroanatomy. Neuroanatomy has gone to the extent where the questions are at least one image-based question is there almost every time. So, images are very important in this portion. Real cadaveric images, at time radiological images, and identification of the structure in that. And we will also talk about a little embryology in this session as well. In the embryo part, again, emphasizing mainly on the topics asked in the recent time. So let's get started with the neuroanatomy. Now, as you people already have a discussion on the neurophysiology in the previous ATP, and I remember that ma'am discussed about the tracts with you guys. So I'm not going into the spinal cord area because the tracts are already being discussed. The question, but in the recent time, there's a question asked on the corticospinal tract, the level of decussation, where it decussates. There's a question which is asked on the Wallenberg syndrome. So, I mean, we need to have a little idea about that if the different section of the brainstem are given and what syndromes can be asked from there and what could be the like major features to be looked into it. Not everything in detail, but yeah, major part. And the main question that we have been seeing in the last few years is about identification. They give you a picture, a transverse section, a coronal section, a sagittal section, and they will ask you about the different, what do you say, the different structure to be identified. Like internal capsule was one of the question asked here. Paracentral lobule was a question asked. Internal, this lentiform nucleus is one of the question asked. Insula is a question asked here. All these are the question asked in the sections of the brains here. So I'll make sure that I'll cover up all the three sections of the brain so that if you get any image-based question, you will not have any difficulty at identifying those images in there. Thank you, Abhinandan. Thank you. So, let me tell you a little about the corticospinal tract. Guys, go in all the descending tracts. There are multiple descending tracts we have. But in all the descending tract, the one tract which holds the most important, is the corticospinal tract because it is for the voluntary movement. Corticospinal tract, it's coming from the cortex to the spinal cord. It is a part of pyramidal tract system. So if I just may very quickly tell you a little about the corticospinal tract before we move on to the next portion. The corticospinal tract is basically going to start from the motor cortex. Corticospinal tract will start from the motor cortex, and motor cortex is area number 4 in the brain. In the precentral gyrus, there is area number 4. This is where the motor cortex is present, and from the motor cortex, the pyramidal tract or corticospinal tract will begin. Let's assume that this is the brainstem. Let's say this box here is representing the brainstem, and this midline is a midline of the brainstem here. Now what you'll see that corticospinal tract, it is starting from the motor cortex, will descend on the same side. Like let's say it's starting from the right side of the brain, right side of the cerebrum. So it descends on the right side only, and it reaches the lower part of medulla oblongata. This is what corticospinal tract is doing. It is reaching the lower medulla oblongata. Look at this area which I'm highlighting. Let's say it is a medulla oblongata. So there will be midbrain, pons, and medulla, and it is a medulla. And once it reaches the medulla oblongata, lower medulla oblongata to be more precise, it is going to decussate onto the contralateral side. Not entirely, around 85 to 90% fibers will decussate on the contralateral side. And it will reach the lateral side of the spinal cord, that is called as the lateral corticospinal tract. Lateral corticospinal tract. Whereas the remaining 10 to 15% fibers, they're running on the same side, that is the anterior corticospinal tract. That is anterior corticospinal tract. Okay. So see, basically the question was asked on that where the decussation takes place. The corticospinal tract will cross over, and the answer to that is in the lower medulla oblongata. So it's the lower part of medulla oblongata where the pyramidal, आप इसको pyramidal decussation ही बोल सकते हैं. You can even call it a motor decussation. You can call it a pyramidal or motor decussation. Pyramidal or motor decussation, which takes place in the lower part of medulla oblongata. And as a result, when you look at the spinal cord, this tract is actually going to reach the lateral aspect of the spinal cord. So this is called as a lateral corticospinal tract. I'm writing CST, corticospinal, guys. That is lateral corticospinal tract. And this tract is going to reach the anterior aspect of spinal cord. So we call it an anterior corticospinal tract. Lateral corticospinal and anterior corticospinal tract. See, what's the difference between the two? First of all, lateral corticospinal tract is approximately 85 to 90% of the fibers of the overall corticospinal tract. जो पूरा tract आया था उसका 85% fiber goes into the lateral corticospinal tract and approximately 15% fibers will be seen running in the anterior corticospinal. What is another difference? Another difference is that, and that you can remember again from their name itself, guys. L for lateral, and the word L will remind you of limbs. A for anterior, and A will remind you of axial. That means lateral corticospinal tract is mainly to supply the limb muscles. It is going to supply the limb muscles. Whereas anterior corticospinal tract is going to supply the axial muscles. Intercostal muscles, abdominal muscles, जो है वो supplied by the anterior corticospinal tract. So the tract is for the voluntary movement. We all know that corticospinal tract is for the voluntary movement. So one question is that where the decussation takes place, and that is obviously in the lower medulla oblongata. And as a result of decussation, you will see lateral corticospinal tract, which is 85% fibers, they are supplying the limb muscles, and anterior corticospinal tract, they are supplying the axial musculature or the intercostal or abdominal muscles. So that's the corticospinal tract for you. एक चीज ध्यान रखिएगा, the way the lateral corticospinal tract is reaching below, it is going to supply the muscles, limb muscles of contralateral side. Limb muscles of contralateral side. That means if I talk about the right side corticospinal tract, it is going to supply the limb muscles of the left side. That is why whenever we have injury in the brainstem, we'll say we have a contralateral hemiplegia, guys. Hemiplegia कौन side पे हो? Contralateral side. But contralateral hemiplegia will be there if the injury is there, right? What about anterior corticospinal tract? Anterior corticospinal tract is supplying the axial muscle. It is supplying the axial muscle of the same side as well as contralateral side. That means bilateral innervation. Bilateral innervation, guys. आपकी जो axial muscles हैं, intercostal muscles, abdominal muscles, they are supplied by both sides. That means your anterior corticospinal tract, when it reaches the spinal cord, it is not only supplying the axial muscle of the same side as well as of the opposite side as well. इसलिए axial muscles usually बच जाती हैं. Just imagine if a patient is having an injury to the corticospinal tract in this area. So obviously there is a limb paralysis on the opposite side. Contralateral limb paralysis तो होगा. But why we do not talk about the axial muscle paralysis? Why we don't say that there is a intercostal muscle paralysis or abdominal muscle paralysis? Because abdominal muscle and intercostal muscle, they are supplied by both sides. So even if one side corticospinal tract is injured, दूसरी side वाला तो अभी भी है ना, तो it will supply the axial muscle. That is the reason that whenever you talk about the injury of the corticospinal tract in the brainstem or in the internal capsule or even higher above, we just talk about the limb paralysis. हम axial muscle के बारे में बात ही नहीं करते because they are generally spared because of they having a bilateral innervation. Bilateral innervation. Okay, so this was one of the question asked, guys, that what is the level of the corticospinal tract decussation? That is the lower part of medulla oblongata. Okay. Yes, Ranjan. That is opposite side से मिलेगा, दोनों side से मिलता है. देखो अभी coming to this part here, see, there's a question asked on the syndrome of the brainstem, and then I'll go to the question actually. In the brainstem syndrome, guys, obviously this is something to be discussed in your in your medicine class, neuromedicine. You will be talking more about that. But if I just give you a little overall idea about कि if there is a syndrome of the midbrain, pons and medulla oblongata, एक basic out approach क्या? I mean, I'm not going into the detail of that because the questions are not asked in that much of detail. But a little overview of the midbrain syndrome, a pontine syndrome, and medullary syndrome. Just major की बात करते हैं. And what are the major things you have to look into the option and get the answer based on that? Though I'll tell you the way the question will be asked to you will be either they will give you the symptoms of the patient and will ask you what part of the brainstem is involved, or it could be image based question जिसमें आपको एक image दे देंगे and they will ask you, okay, lesion is shown in this and this and this part, so what will be the symptom of the patient? So could be either way. So I wanted to understand this thing carefully. So first let me tell you a little about the midbrain. Midbrain syndrome Pontine syndrome, and obviously मिडिलरी सिंड्रोम, राइट. तो हम तीनों को लेके चलते साथ में, मिड ब्रेन, pons and middle oblongata. Now honestly, to understand these syndromes we need to know a lot of details inside about the lemniscus and the nuclei, but what I'm trying to do here, I'm just trying to give you a little simple approach that how to look into the major syndrome. अभी again I keep on repeating that we are not looking at every syndrome. मैं सिर्फ कुछ major specific syndrome बोल रहा हूँ जिनके ऊपर question आने के chances हैं. Like for example, one thing is you need to identify the section of the brainstem. बेटा मिड ब्रेन का सेक्शन अगर आप देखोगे, मिड ब्रेन में आपको जो मेजर चीज दिखाई देगी, द वन थिंग दैट यू विल मेक यू अंडरस्टैंड द मिड ब्रेन is a section shown in such a way that the peduncles will be visible to you. Cerebral peduncles are visible to you, and these are the collicles at the back. So that is how the transverse section of the midbrain is. That's how the transverse section of the midbrain is going to look like. There is substantia nigra. Let's say that's a colliculus. The midbrain section में आपको dorsal side पे you will see superior colliculus, inferior colliculus. Let's say I'm just putting a superior colliculus there, and this area here is the cerebral peduncle. The reason we call it a cerebral peduncle, although it is a part of the midbrain, but we call it cerebral peduncle because all the descending tracts of cerebrum are here only. Corticospinal tract, corticonuclear tract, सब यहीं पर ही होता है. तो नाम क्या है? Cerebral peduncle. It's a part of midbrain, but we call it cerebral peduncle. We call it a cerebral peduncle. Okay. Because a section is taken from midbrain at the level of superior colliculus, so guys, what you expect to see here? आपको यहाँ से third nerve दिखाई देगा. Third cranial, the third nerve will be seen coming out from this area. Oculomotor nerve will be seen coming out from this area. Oculomotor nerve. Yes, Ranjan, there are many syndrome. Weber's है, Benedict है, Claude syndrome है, Perinol syndrome है, pinpoint people. There are a lot of syndrome there. As I said, I'm focusing on the major syndrome, and that one main syndrome जिस पे ज़्यादातर question पूछते हैं midbrain के ऊपर, that is a Weber's syndrome. Now, in the Weber's syndrome, you will see that this area of the midbrain will get affected. And if this ventromedial, anterior medial portion of the midbrain is getting affected, then what will be the things that you will see involved? Third nerve involvement, of course. Third nerve के साथ इस एरिया के अंदर यहाँ पर आपको in this area, guys, you will see upper motor neuron of facial nerve are present here in this area, and corticospinal tract, guys, the tract we just talked about, corticospinal tract or pyramidal tract, will be seen in that area. Corticospinal tract will be seen in this area, particularly where we have this. And that is why the syndrome that you're looking at right now, it is a Weber's syndrome. This syndrome here is a Weber's syndrome. And again, Weber's syndrome, there could be involvement of other things also. Like in Weber's syndrome, there could be involvement of substantia nigra, there could be involvement of red nucleus. But again, looking at the main thing, वेबर सिंड्रोम की मेन चीज क्या है यहाँ पर? एक तो थर्ड नर्व इन्वॉल्वमेंट, थर्ड नर्व इंजरीज देयर, थर्ड नर्व इन्वॉल्वमेंट विल बी देयर गाइस. एंड यू नो थर्ड नर्व फीचर्स, टोसिस होगा. द थर्ड नर्व फीचर्स में क्या होगा गाइस? द पेशेंट विल हैव अ टोसिस, देयर इज अ डाइवर्जेंट स्क्विंट, देयर इज अ लॉस ऑफ लाइट रिफ्लेक्स, लॉस ऑफ पिपुलरी रिफ्लेक्स. वही, आई एम श्योर दैट यू रेड अबाउट थर्ड नर्व इन डिटेल. So because of third nerve palsy, there is a ipsilateral ptosis. There is a ipsilateral divergent squint because medial rectus muscle is not working, so lateral rectus is working. So divergent squint. Patient की जो eye होगी, that will be abducted, out, down, out. That is eyeball. That is divergent squint is there. That is because of third nerve palsy. Upper motor neuron of facial nerve, guys. We just discussed that upper motor neuron of facial nerve में injury होगा, so that will be a contralateral paralysis. So there will be contralateral paralysis of lower part of face or lower half of face. Contralateral paralysis of lower half of face, and also there will be corticospinal tract injury. And guys, we said if there is a corticospinal tract injury, then it will lead to the contralateral limb paralysis, or you can say contralateral hemiplegia. Contralateral limb paralysis or simply contralateral hemiplegia. Just wait a second. So that is about the major syndrome of the midbrain. That is the Weber syndrome, guys. Weber syndrome, as you can see, what is happening in the Weber syndrome? There is an involvement of third nerve, there is an involvement of corticospinal tract और facial nerve का upper motor neuron involved होगा, and that's one of the most asked question from midbrain. Weber syndrome, Benedict syndrome भी होता है यहाँ पर, Peyronie's syndrome, as you mentioned, but this is something which is very very commonly asked here. Yeah. Yes, बेटा, upper motor neuron होगा तो spasticity होगा ना. If it is a lower motor neuron lesion, it is a flaccidity, but if it is a upper motor neuron, there will be a spasticity in that case here. So that is about one major syndrome from midbrain. Similarly, let me tell you a couple of them from the pons. Well, when you look at the section of the pons, guys, what you will notice that transverse section of pons के अंदर आपको दो major चीजें दिखाई देंगी. One, let me just draw this for you first. When you take a transverse section of pons, guys, first of all, you will see that the anterior most portion of the pons here, this is where the corticospinal tract. Corticospinal tract will be seen in the throughout the brainstem. So that is the corticospinal tract. I'm writing CST again. That is a corticospinal tract. Let me draw it on one side only. Then you will see a nerve which is coming out from here. That is a sixth nerve. The nerve which is winding around the sixth nucleus and coming out, that is the seventh nerve. We all know about the internal gene of the facial nerve, so that is the seventh nerve. And if I go further more lateral, you will even see eighth nerve coming out from there. Sixth, seventh, and eighth nerve. All the three nerves, ये तीनों के तीन nerve pons से निकल के आती है, like especially from the pontomedullary junction, which I will tell you in the next part. All the three nerves, they actually comes out from the pontomedullary junction. Okay, so when you look at this section of pons, I just need to take your attention to a couple of things there. There is one lemniscus which you will appreciate present on the lateral side, and this lemniscus is called as a spinal lemniscus. I'll tell you its function. The spinal lemniscus will be seen more toward the lateral side. Again, there are many other things that you will see in this picture. Medial lemniscus, rubrospinal tract, बहुत सारी चीजें present है यहाँ पर. But I again will taking your attention to something particular. So there is one syndrome that is going to affect this basilar part, the ventral part of the basilar part of pons, जिसमें ये सारे structures involved होंगे, guys. Look at the involvement of the corticospinal tract, sixth nerve and seventh nerve. Now this important syndrome on which the questions can be asked is a Millard-Gubler's syndrome. जो मैंने यहाँ पे blue में mark किया है, that syndrome is a Millard-Gubler. That syndrome is a Millard-Gubler's syndrome. Let me use the same highlighter here. And what you will see in the Millard-Gubler syndrome, guys, first of all, look at the involvement of sixth nerve, seventh nerve, and there is involvement of the CST. There is a corticospinal tract. Sixth nerve, seventh nerve, and corticospinal tract. अब देखो यार, sixth nerve जाएगा तो इस बार which muscle is affected? Exactly. There is the lateral rectus muscle is gone. अभी lateral rectus काम नहीं करेगा तो eyeball will come into an adducted position. So there is a ipsilateral convergent squint. इस बार convergent squint है, guys. It's a convergent squint because lateral rectus is not working. Facial nerve, again facial nerve is not working, guys. देखो दोनों केस में difference क्या है? In the previous case, it was a upper motor neuron of facial nerve. And we already discussed कि अगर upper motor neuron lesion होगा facial nerve का तो there is a contralateral facial paralysis. But now I'm saying facial nerve is injured. Nerve is injured. Lower motor neuron lesion है. And lower motor neuron lesion के अंदर there is a ipsilateral facial paralysis. So patient will have a ipsilateral facial paralysis. The entire face of that side will be gone. Ipsilateral facial paralysis will be seen. And corticospinal tract involvement. Once again, it will lead to what? Contralateral limb paralysis, or you can say contralateral hemiplegia. Contralateral hemiplegia. अब देखो दोनों केस में एक चीज मैं चाहता हूँ आप एक इंटरेस्टिंग कंपैरिजन करो, बिकॉज व्हेन यू गेट दिस क्वेश्चन इन द एग्जाम, विद इन दैट 30-40 seconds you have to read the question, analyze and get the answer. See, पहले दोनों केस में अलग अलग नर्व डिस्कस, गाइस. As we know, third nerve comes out from midbrain and seventh nerve, sixth nerve, they're coming from the pons. So nerves always will give you an idea about कि we are talking about the syndrome of midbrain की बात कर रहे हैं, pons की बात कर रहे हैं, medulla की बात कर रहे हैं. So nerve is the main thing to focus on. If you have a case जिसमें patient को third nerve palsy है and there is a contralateral limb paralysis, like एक side का third nerve palsy और दूसरी side का limb paralysis है, तो it is what syndrome? It is Weber syndrome. In this case, you will see on one side patient is having a facial paralysis and on the other side there is a limb paralysis. इसमें एक साइड में facial nerve involvement, facial paralysis, opposite side पे again limb involvement है. So it is what syndrome? It is a Millard-Gubbler syndrome. Always look for the cranial nerve. In the syndrome based question, अगर आप cranial nerve को पकड़ लोगे, once you identify the cranial nerve, आपको generally, not always, but generally क्या करना होता है, आपको opposite side पे देखना होता है कि what cranial nerve is affected और opposite side of body में क्या हो रहा है. So ipsilateral cranial nerve and what is happening onto the contralateral side of the body will give you a great hint about the syndromes of the brainstem. ये method mostly काम करता है, हर जगह तो नहीं, but in most of the syndrome it will work. So this is how you have to look at the, whenever you get a question on the brainstem syndrome, look at, okay, cranial nerve ये वाला involved हुआ है, and with that what is happening to the opposite side of body. Is there is a motor loss, is there a paralysis, is there is a sensory loss on the other side of the body, lower body की बात कर रहा हूँ. Okay, and let me take your attention to the medullary syndrome also, guys. हमने एक discuss किया mid brain से, एक हमने pons से. But for the medulla, we have to discuss two syndrome because in the medulla there is a question. There is a high probability of getting a question either on medial medullary syndrome or lateral medullary syndrome. और आपको जो recently question आया था वो lateral medullary syndrome के ऊपर आया था. But look how the picture will look like in the medulla oblongata transverse section. This is the transverse section of the medulla oblongata. जिसमें से this is the pyramid or the corticospinal tract is here. That's a pyramid जिसमें corticospinal tract present है. Here is a nucleus present in the medulla oblongata which is called as the inferior olivary nucleus. And there are some peduncles present at the back which is called as the inferior cerebellar peduncle. ICP. Inferior cerebellar peduncle. ये elevation जो आपको दिख रहा है, this elevation is called as a olive. And the third elevation that you see in the front, it is because of corticospinal tract. जिसको हम pyramid भी बोलते हैं, corticospinal tract. Okay, let me focus on one side only, guys. So इसको दो part में divide कर लेते हैं. Now, if you look at close to the midline here in the medulla oblongata, hypoglossal nucleus will be seen, and you will see hypoglossal nerve is coming out like this between the pyramid and olive. Pyramid और olive के बीच में से निकल के आ रहा है. That nerve is the hypoglossal nerve. So third nerve हमने कहाँ देखा था? In the midbrain. Seventh nerve, sixth nerve हमने कहाँ देखा? Pons. और अभी हम देख रहे हैं medulla oblongata where hypoglossal nerve is one of the nerve visible to you, hypoglossal nerve to be seen. And there is a medial lemniscus also present there. There is a medial lemniscus. Now guys, the first syndrome that I'm talking to you about is a syndrome in which all these midline structures will get affected. Sirf midline wale. Medial medullary syndrome. This syndrome here is called as a medial medullary syndrome. And again, medial medullary syndrome में I'm not looking into everything. I just need to look at the, देखो तीन चीजें आपको दिख रही हैं यहाँ पर. medial lemniscus है एक तो. There is a lemniscus called as a medial lemniscus which is getting affected. Number one. Hypoglossal nerve का involvement, a nerve, hypoglossal nerve is involved. And which tract again? Once again the same story, guys. Corticospinal tract की injury है. अभी medial lemniscus is basically carrying. Medial lemniscus is something which is carrying the sensation from the contralateral side of the body. Pain, temperature, not temperature, pain, not even pain, sorry. Medial lemniscus mainly दो tracts से बनता है, dorsal column tract and anterior spinothalamic tract. So broadly, if the medial lemniscus, in fact कभी भी किसी भी lemniscus को injury हो, ध्यान रखिएगा, any injury to any lemniscus effect is always on the contralateral side. बेटा lemniscus बनते ही contralateral side पे. So if a tract is running in the spinal cord, once the tract reaches the brainstem and it is present on the opposite side, contralateral side पे, तभी उसको lemniscus बोलते हैं. So injury to any lemniscus, the first word that should come to your mind is contralateral. Contralateral loss होगा उसके अंदर, right? So yes, you're right, Monica, that there will be contralateral loss of touch, vibration, कॉन्शियस प्रोप्रियोसेप्शन एक्सेट्रा. आई मीन हमें इतना डिटेल में जाने की जरूरत नहीं. टच और वाइब्रेशन याद रखो, चलेगा, दैट इज फाइन. बिकॉज द मेन डिफरेंशिएटिंग फीचर इज नॉट दिस, वो नेक्स्ट दो है. हाइपोग्लॉसल नर्व इज इंजर्ड, गाइस. हाइपोग्लॉसल नर्व इज इंजर्ड, सो देयर इज ए इप्सिलैटरल टंग पैरालिसिस. Ipsilateral tongue paralysis. I told you that the tongue will deviate toward the ipsilateral side only. Ipsilateral tongue paralysis here. And corticospinal tract is involved. That means there is contralateral limb paralysis or contralateral limb muscle involvement, or you can say contralateral hemiplegia. Again, देखो guys, can you see something unique here? इस बार there is a tongue paralysis of one side and there is a limb paralysis of the other side here. Till now, the three syndromes that we talked about, सब में कुछ ना कुछ common है. In the Weber syndrome, there is a third nerve paralysis with contralateral hemiplegia. In the in the Millard-Gobler syndrome, we saw in the Pons that there is a ipsilateral facial paralysis, contralateral hemiplegia. और इस बार there is a ipsilateral tongue paralysis and contralateral hemiplegia. So तीनों केस में contralateral hemiplegia तो हो रहा है. There is a contralateral limb paralysis, contralateral limb paralysis, contralateral limb paralysis. But nerve is important. Ipsilateral third nerve involved है तो Weber's midbrain का syndrome है. Facial nerve involved है तो Pons का syndrome, Millard-Gobler. और hypoglossal nerve involved है तो it is a syndrome of what? Medulla oblongata. So that's why it's very important to keep an eye on the cranial nerves. कि कौन सा cranial nerve involved है, then only you can judge कि it is basically at what level of the brainstem it is getting affected. Now coming to the question which is asked to you in the recent time, it's on the lateral medullary syndrome, also called as a Wallenberg syndrome. Now this was a medial medullary syndrome. Now let me take you to the lateral medullary syndrome. Now there are multiple structures present on the lateral side. Again, I'm not going into all of them. I just need to take your attention to something here. Like first of all, there is a nucleus present here called as a nucleus ambiguus. And I hope you know that nucleus ambiguus is a common nucleus. Nucleus ambiguus is a common nucleus जिससे हमारी कौन सी nerves निकल के आती हैं? It's the 9th, 10th and 11th nerve will be seen coming out of the nucleus ambiguous. 9th, 10th and 11th nerve will be seen coming out of the nucleus ambiguous. 9th, 10th, 11th nerve are coming out of the nucleus ambiguous. Also, this peduncle is what? Inferior cerebellar peduncle involvement is there. Inferior cerebellar peduncle. Now again, without going into any further detail, again in the lateral medullary syndrome, there are so many things which can get involved, guys. Again, you probably read about them in your neuromedicine class, or you will be reading them. But my focus is that if you look at this syndrome going to affect the lateral side of the brain stem, lateral side of the medulla oblongata especially, ये दो structure को ध्यान रखो, आपको you'll get the answer. अभी inferior cerebellar peduncle involvement, guys. If inferior cerebellar peduncle is involved, so patient will have a ipsilateral ataxia. आप cerebellum की tract को अगर involve करोगे, obviously cerebellum, inferior cerebellar peduncle. It's the peduncle which is taking the tract toward the cerebellum. So ipsilateral ataxia will be there. And nucleus ambiguous is involved. That means 9th nerve भी गया, 10th nerve भी गया, 11th nerve भी गया. So the patient will have ipsilateral dysarthria, dysphagia. So all the dysphagia, dysarthria will be there. So this time it's an ipsilateral ataxia and there is an ipsilateral dysarthria and dysphagia will also be there. The patient will have a dysphagia and dysarthria as well. Pain and temperature loss वगैरह भी होता है, but again guys, I'm looking at the feature or based on which the question is asked. Although for the differentiation point of view, there's one important thing to be discussed in here. There is an involvement of a lemniscus called as a spinal lemniscus. There's an involvement of the spinal lemniscus which is carrying a pain and temperature. So this patient will have, or lemniscus injury is the contralateral. There will be a contralateral loss of pain and temperature from the body. Contralateral loss of pain and temperature from the body. This syndrome here is the lateral medullary syndrome or the Wallenberg syndrome. That is lateral medullary syndrome or Wallenberg syndrome. Lateral medullary or the Wallenberg syndrome. Yes, Ranjan, you're absolutely right. There will be the hoarseness of the voice also. Dysarthria hai, dysphagia hai, hoarseness of voice hai. You know, because 11th, 10th nerve is also, recurrent laryngeal nerve is also involved in that case. So obviously dysarthria will be there, dysphagia will be there, and there will be hoarseness of the voice as well. So again the point is that in the lateral medullary syndrome, patient को ipsilateral ataxia है, ठीक है, ipsilateral side का dysphagia भी होगा, dyspnea भी होगा, dysarthria भी होगा, hoarseness of voice भी होगा, and there is a contralateral loss of pain and temperature. So again, summarizing everything at one place, guys, when you look at all the major syndromes, इसके अलावा और भी discuss करोगे आप, when you have major syndromes of the brainstem, generally try to look at it in this way, कि try to find out which cranial nerve is involved And with that cranial nerve, look at what is happening to the other side of the body. अगर मैं इन चारों सिंड्रोम को दोबारा से आपके सामने बोलूं, देखो वेबर सिंड्रोम के अंदर नर्व इप्सिलैटरल थर्ड नर्व इन्वॉल्वमेंट, कॉन्ट्रालैटरल पैरालिसिस. मिलर्ड गुबलर सिंड्रोम के अंदर इप्सिलैटरल फेशियल नर्व इन्वॉल्वमेंट, कॉन्ट्रालैटरल लिम्ब पैरालिसिस. मीडियल मेडुलरी सिंड्रोम के अंदर इप्सिलैटरल हाइपोग्लॉसल नर्व इन्वॉल्वमेंट, कॉन्ट्रालैटरल पैरालिसिस. और लैटरल मेडुलरी सिंड्रोम के अंदर देयर इज इप्सिलैटरल, अगेन 9, 10th, 11th हम जाएंगे तो इप्सिलैटरल 9, 10th, 11th dysphagia, dyspnea will be there, and contralateral loss of pain and temperature from the body. So if you remember this, I'm sure that you still will be able to mark the answer on the syndromes of the brainstem. हालांकि it's a very detailed topic. आप जितना पढ़ोगे इसको डिटेल में you have things to go into. But from the before the exam, I would say अगर इतना भी आपको याद रहेगा तो I'm pretty sure that you'll be able to fetch the right answer to the question. So देखो, this was the question asked to you. The question said, a woman presents with the sudden onset of the dysphagia, dysarthria, and gait ataxia. Acute infarction in the right dorsolateral medulla. बताई दिया ना dorsolateral medulla के बारे में. What is the likely diagnosis? Lateral medullary syndrome. नाम ही बता रहा है dorsolateral side of medulla. So it's a lateral medullary syndrome or Wallenberg syndrome this patient is suffering from. Okay. Chalo. Now moving on to the next part, guys, where some different sections are visible to you, and these sections have always been important because when you see the brainstem from that's a view of the brainstem from the front, that's a brainstem from the back here, and then we have other sections also. So when you see the brainstem from the front, you need to identify the cranial nerves. Simple questions are यहाँ पूछते हैं, cranial nerve को identify करना है, nothing else. So in this picture, when you look at the ventral aspect of the brainstem, look at the highlighted area here, that is a midbrain portion called as cerebral peduncle. तो ये तो midbrain का part होगा. This is called as cerebral peduncle. It's a part of midbrain. Cerebral peduncle. It's a part of the midbrain. The second highlighted area that I'm showing you here, that is the pons. This whole thing is the pons. And then finally, the third area which I'm highlighting for you, this whole thing is the medulla oblongata. Right, so the three parts of the brainstem which are clearly visible to you in the three different color code here. You're looking at the midbrain, pons, and medulla oblongata. Okay, if you see a nerve coming out between the two peduncle, दो peduncle के बीच में से nerve निकल के आ रही है, guys, this nerve is a third nerve. The nerve coming from interpeduncular fossa, and that is a third nerve. Third nerve, which is a content of the interpeduncular fossa. The only nerve that you see coming out from the dorsal side, that is the fourth nerve, the thinnest cranial nerve, and that is coming from dorsal side of the brainstem. ये peduncle के आपको around मिलेगी. So when you're looking at the picture of the brainstem, and if you're looking at the peduncle, cerebral peduncle, आपको दो nerve notice करने यहाँ पे. Third nerve, which is coming out from interpeduncular fossa, and fourth nerve is coming from the dorsal aspect of the brainstem. You can see fourth nerve पीछे से घूम के आ रहा है. It's the thinnest cranial nerve also. देखो यार, pons, there are multiple nuclei present inside the pons, but the only nerve which is actually emerging from the ventral surface of pons is the fifth nerve. So the nerve that you see, thickest cranial nerve which is coming out from the ventral surface of pons, that is the trigeminal nerve or the fifth nerve. Pontomedullary junction. When you look at the junction, pons or medullary junction को देखो, the three nerves which are visible to you, that is the sixth nerve. Let me just mark them meticulously. There is sixth nerve. Then these two here, there is a seventh nerve. Sensory motor part दोनों साथ में दिखाई दे रहे हैं. That is a seventh nerve. And furthermore lateral, that is the eighth nerve. That is the eighth nerve. Sixth, seventh, and eighth. Sixth, seventh, and eighth. These three nerves are leaving the brainstem from pontomedullary junction. The nerves are coming out from pontomedullary junction. 6, 7, and 8. Exactly. 6, 7, 8 from the pontomedullary junction. In the medulla oblongata, the दो major landmark आपको दिख रहे हैं, guys. This here is olive. That elevation is because of olive, and this midline elevation is basically pyramid. So you're looking at the olive and pyramid. Now the nerve that you see coming out lateral to olive, can you see the three nerves over there which are lateral to olive, guys? Olive के laterally present है, and these three nerves which are seen lateral to the olive or posterolateral to the olive, that is the 9th, 10th and 11th nerve. 9, 10th, 11th nerve can be seen coming out just lateral. Olive के just lateral दिख रही है, posterior lateral दिखाई दे रही है. And the only nerve that you see coming out between pyramid and olive, that is the hypoglossal nerve. जो अकेला nerve आपको दिख रहा है between the pyramid and olive, that is hypoglossal nerve. In fact, मैं चाहता हूँ इस पिक्चर को आप पीछे वाली इमेज से कंपेयर भी करो. देखो, if you look at this here, the nerve coming out between pyramid and olive is 12th nerve, and the nerve which is lateral to the olive, it is a 9th, 10th and 11th nerve. And this is something that you will notice in this picture also, guys. When we discuss the Wallenberg syndrome or lateral medullary syndrome, can you see the nerve which is coming out between the pyramid and olive? That is 12th nerve. देखो ये pyramid है यहाँ पर, that is a corticospinal tract, and ये olive है. तो pyramid और olive के बीच में जो nerve आ रहा है, that is the 12th nerve. And more lateral to olive or posterolateral, olive के भी और पीछे जाएंगे, posterolateral. So you can see the nerve coming out from there is what nerve? 9th nerve, 10th nerve and 11th nerve. The same thing which we drew in the transverse section, we're trying to correlate here from the ventral aspect also. The nerve seen coming out just posterolateral to olive is 9th, 10th, 11th. Between pyramid and olive is the hypoglossal nerve. Now it could be a clinical question, it could be non-clinical question, doesn't matter. But identifying the nerve is it's a basic requirement here. कि ventral aspect of brainstem में आपको nerve identify करना ही करना है. Third nerve, fourth nerve, fifth nerve, sixth, seventh and eighth, 9th, 10th, 11th, 12th nerve, where they're present, how to identify them. चलिए, ये तो हुआ regarding ventral aspect of brainstem, guys. अब जरा turn करते हैं. फ्रॉम द डॉर्सल एस्पेक्ट ऑफ द ब्रेन स्टेम, बस एक ही इंपॉर्टेंट चीज हमें डिस्कस करनी है यहाँ पर. पहले देखो, डॉर्सल एस्पेक्ट ऑफ ब्रेन स्टेम आप देखोगे तो आपको कॉलिकुलस दिखाई देंगे. दैट इज सुपीरियर कॉलिकुलस, दैट इज इंफीरियर कॉलिकुलस. दिस इज द डॉर्सल एस्पेक्ट ऑफ द ब्रेन स्टेम. यू आर लुकिंग एट द डॉर्सल एस्पेक्ट ऑफ द ब्रेन स्टेम. The dorsal aspect of the brainstem. So midbrain area में you can see colliculus, superior colliculus, inferior colliculus are visible to you. That's how they will look like. The only cranial nerve which can be seen coming out from the dorsal aspect of brainstem is the fourth nerve, the trochlear nerve. The trochlear nerve is seen. And I would say, guys, बाकी सब चीजें छोड़ो, because you probably would have discussed about the dorsal aspect of the brainstem about in detail about them. But एक major चीज इसके ऊपर question पूछते हैं, and that is this elevation present in the floor of fourth ventricle. And this elevation present in the floor of fourth ventricle is what? It is a facial colliculus. This is facial colliculus. अब ये facial colliculus इतना important क्यों है, इस पे क्यों इतने question पूछते हैं? Guys, we already know what is facial colliculus. That we know that sixth nucleus is there, and the sixth nucleus is surrounded by the seventh nerve. So here is the seventh nucleus also, sixth nucleus, seventh nucleus is there, and facial nerve ऐसे घूम के जाता है, it winds around the sixth nucleus and comes out. So the journey of facial nerve is around this sixth nucleus, and that colliculus is called as a facial colliculus. So ये जो आपको bulge दिखाई दे रहा है, now there are two type of question here. They might show you the picture of the facial colliculus, and if the question is asked to you, what is the nucleus present deep to the following elevation? Nucleus deep to this elevation is what nucleus? It is the sixth nucleus. It is the abducent nucleus which is present deep to it here. But this is where the people get it wrong at times. If the question is asked कि अगर facial colliculus को injury हुआ, if you have a patient who is having an injury to the facial colliculus, is the sixth nucleus most commonly injured structure? No. Whenever you have injury to the facial colliculus, सबसे पहले तो nerve जाएगी ना बेटा. Nucleus is surrounded by the nerve. So whenever there is an injury to the facial colliculus, पहले तो nerve injured होगी, बाद में nucleus की बारी आएगी. So if they ask you what is the nucleus deep to it, answer is sixth nucleus. But if the question says that there is an injury to the facial colliculus, there is an injury to the facial colliculus, so remember that facial nerve injury is something which is more commonly seen. The patient will have a ipsilateral facial paralysis. It's a lower motor neuron lesion. So ipsilateral facial paralysis, या कोई भी facial muscle option में दियो, go with that here. Sixth nucleus injured हो सकता है. I'm not saying sixth nucleus can't get injured here, but whenever there is an injury to the facial colliculus, the structure which is present around the nucleus, that is nerve बाहर present है, it is surrounding the nucleus, nerve पहले injured होगा. So injury to facial colliculus पे जब question पूछेंगे आपसे, so please be careful, you have to go with the facial muscle involvement. Muscle of face choose करना है. हाँ, if the question specifically says कि देयर इज ए इंजरी टू द न्यूक्लियस प्रेजेंट डीप टू द फेशियल, अगर क्वेश्चन में लिख ही दिया न्यूक्लियस तब तो ऑब्वियसली 6 न्यूक्लियस इन्वॉल्वमेंट होगा, लैटरल रेक्टस मसल जाएगा. बट आइडियली द क्वेश्चन इज अबाउट इंजरी टू फेशियल कॉलिक्युलस, और आपको फेशियल नर्व के साथ जाना होता है. फेशियल नर्व इज द वन विच इज गेटिंग अफेक्टेड एंड द मसल सप्लाइड बाय फेशियल नर्व आर द मसल ऑफ फेशियल एक्सप्रेशन. मसल ऑफ फेशियल एक्सप्रेशन. बेटा मैं ये पीडीएफ के लिए बोल चुका, पहले ही बोल चुका, बराबर बोल रहा हूँ, पीडीएफ आपको मिल जाएगा आपको. लेट द सेशन गेट ओवर. सारे सेशन खत्म करने के बाद इसके बाद एक और सेशन करेंगे हम, उसको भी खत्म करने के बाद देन पीडीएफ, द कंबाइंड पीडीएफ, मैं इस पूरे का एक ही पीडीएफ इसको मैं स्टोर करके एंड आई शेयर द लिंक इन द ग्रुप हियर. सो डोंट वरी, पीडीएफ तो आपको मिलना ही मिलना है उसमें. अब उसके बारे में मत सोचो अभी जस्ट पे अटेंशन टू व्हाट वी आर डिस्कसिंग हियर. पीडीएफ को साइड में रखो अभी. इफ यू आर अंडरस्टैंडिंग इट, पीडीएफ तो आपको मिल ही जाना है उसमें. दैट इज नॉट गोइंग टू बी द प्रॉब्लम. Right, so guys, this is about the ventral aspect of the brainstem, dorsal aspect of the brainstem. अगर ventral aspect से क्वेश्चन पूछेंगे तो there are highest probability कि कोई ना कोई cranial पूछेंगे आपसे. dorsal aspect से क्वेश्चन पूछेंगे तो again there is a highest probability कि आपसे facial colliculus पे क्वेश्चन पूछेंगे. Whatever it is, you should be able to answer. चलिए सर, अब आते हैं जरा, let's talk about the section guys. अब 3 possible section है. One is sagittal section. Thank you guys, thank you आपका fan. Interesting name. सर स्पाइनल ट्राइजेमल न्यूक्लियस में इप्सिलैटरल होता है ना? यस. तो बेटा न्यूक्लियस में कोई भी इंजरी हो, जब भी किसी न्यूक्लियस को इंजरी होगा ना तो इफेक्ट इप्सिलैटरल ही होगा भाई. न्यूक्लियस से तो नर्व निकल के जाएगा. लेट्स से माय राइट साइड का न्यूक्लियस इज इंजर्ड, न्यूक्लियस विल गिव आउट द नर्व एंड नर्व विल आल्सो कमिंग आउट फ्रॉम राइट साइड ओनली. सो किसी भी न्यूक्लियस को इंजरी होगी तो इफेक्ट इज ऑलवेज ऑन द इप्सिलैटरल साइड हियर. हाँ, नर्व को इंजरी हो, सॉरी लेमेनिस्कस को इंजरी हो तब कॉन्ट्रलैटरल होगा. ओके चलो गाइज, सो कंटिन्यू विद दैट. सो व्हाट आई सेड कि आपको एक ना एक क्वेश्चन सेक्शन के ऊपर आएगा. इट कुड बी स्टैटिकल सेक्शन. ट्रांसफर सेक्शन इज मोर कॉमनली आस्क्ड. मैंने जो देखा एफएमजी एग्जाम के अंदर ट्रांसफर सेक्शन ज़्यादा कॉमनली पूछते हैं. बट लेट्स नॉट लीव एनी स्टोन अनटर्न्ड. हम स्टैटिकल सेक्शन, ट्रांसफर सेक्शन, कोरनल तीनों सेक्शन कर लेते हैं ताकि वट एवर दे विल आस्क यू टू आइडेंटिफाई यू शुड बी एबल टू डू इट हियर. लेट अस स्टार्ट विद द sagittal section of the brain. और sagittal section of brain में आपको एक और चीज का एडवांटेज है. you'll also come to understand about the third ventricle guys. This picture is going to tell you about the boundary of the third ventricle also. Okay, so this section that you're looking at on the screen right now, it is the sagittal section, a mid sagittal section of the brain, and along with this section we will be able to see the third ventricle as well. तो पहले तो मैं आपकी थर्ड वेंट्रिकल मार्क करता हूँ गाइस. इस पिक्चर में बेटा जो मैं हाईलाइट कर रहा हूँ येलो से, दैट इज अ थर्ड वेंट्रिकल. तो दिस वेंट्रिकल हियर इज अ थर्ड वेंट्रिकल हियर, राइट. सो व्हाट आर द थिंग्स व्हिच आर सराउंडिंग द थर्ड वेंट्रिकल? देखो, आई होप ऑल ऑफ यू कैन सी कॉर्पस कैलोसम. देयर इज अ कॉर्पस कैलोसम देयर, दैट इज नॉट फॉर्मिंग द बाउंड्री. जस्ट बिलो कॉर्पस कैलोसम देयर इज अ सेप्टम कॉल्ड अ सेप्टम पेलुसिडम, again not forming the boundary. I'm just writing them for the sake of completion guys. This is the corpus callosum, the corpus callosum, and this thin septum, this septum which is separating the lateral ventricle, अभी हम next section में देखेंगे इसको. This is called as septum pellucidum. Septum pellucidum, a pellucid septum, a thin translucent septum called as septum pellucidum is there. But corpus callosum and septum pellucidum has no role to play in this third ventricle boundary. Third ventricle boundary में what you'll see guys, on in the roof of the third ventricle आपको दो structure दिखाई दे रहे हैं. One is a white matter bundle that is called as a fornix. I'll tell you more about the fornix in a minute. That is fornix. और fornix के नीचे that plexus there is the choroid plexus. So guys, fornix and choroid plexus, I can say that fornix and choroid plexus, they are forming the roof of the third ventricle. थर्ड वेंट्रिकल रूफ में आ गया फॉर्निक्स एंड कोरोइड प्लेक्सस. आगे की तरफ आते हैं सर. जस्ट इन फ्रंट ऑफ द थर्ड वेंट्रिकल देयर इज अ कमिशर. दिस कमिशरल फाइबर इज कॉल्ड एज ए एंटीरियर कमिशर. देयर इज एंटीरियर कमिशर, एंड जस्ट बिलो द एंटीरियर कमिशर आपको जो लमाइना दिखाई दे रही है, दिस लमाइना इज कॉल्ड एज ए लमाइना टर्मिनालिस. दिस इज लमाइना टर्मिनालिस. लमाइना टर्मिनलिस बेसिकली न्यूरल ट्यूब का सबसे क्रेनियल एंड होता है. मैं आपको एम्ब्रियोलॉजी में थोड़ा और बताऊंगा इसके बारे में. एंटीरियर कमिशर एंड लमाइना टर्मिनलिस, Anterior commissure and lamina terminalis, well, they together forms the anterior wall. They together forms the anterior wall. Posterior wall, guys, posterior wall में you will have the pineal gland. देखो यहाँ पे if you look at that gland over there is a pineal gland. और बेटा pineal gland के superior lamina और inferior lamina दोनों के अंदर ही commissure fiber present है. You can see there is a commissure present in the superior and the inferior lamina. जो ऊपर की तरफ lamina in the upper lamina or the upper this area of this above the pineal gland, this is where a commissure is present called as a habenular commissure. And just below that we have a posterior commissure. Commissure fiber, guys. Corpus callosum is the largest commissure fiber, पर उसके अलावा भी हमारे पास कुछ commissure fibers होते हैं. Like this is a habenular commissure जो pineal gland के ऊपर है, pineal gland नीचे posterior commissure है. And I hope that you can clearly identify that is the aqueduct of Sylvis. This is the aqueduct of Sylvis, which is leading the third ventricle into fourth ventricle. Third ventricle यहाँ पर fourth ventricle है. So that is the aqueduct of Sylvis. So in the sequence, ऊपर से नीचे जाएंगे तो in the sequence habenular commissure, pineal gland, posterior commissure and aqueduct, they're all forming the posterior wall of the third ventricle. All of them are forming the posterior wall of third ventricle. अब what is important is the floor. और देखो floor के अंदर अगर when you go from anterior to posterior, guys, in the floor the most anteriorly placed structure in the floor is the optic chiasma. It's the section through the optic chiasma. Optic chiasma के just पीछे आपको क्या दिखाई दे रहा है? Can you see the infundibulum of pituitary, the stalk of pituitary, or that is infundibulum? That is stalk of pituitary or infundibulum. उसके और पीछे जाएंगे तो you will see this mammillary bodies, which is a part of limbic system. There is a mammillary body. और थोड़ा और पीछे जाएंगे तो then there is a perforating area here called as a posterior perforating substance. That is a posterior perforating substance, guys. This is called as a posterior perforating substance. Optic chiasma, infundibulum, mammillary body, posterior perforating substance. All these are the structures which are present in the floor. They are all present in the floor of this ventricle here. So roof, anterior wall, posterior wall, floor. Well, that is what you are looking at here. That's the structure which is surrounding the third ventricle here. So if the question could be about simple identification. Like if I correctly remember, mammillary body के ऊपर question आया हुआ है. Identifying mammillary body, identify pituitary gland, identify the optic chiasma, identify anterior commissure, identify pineal gland. So कुछ भी identify करा सकते हैं आपसे. But if let's say if it is not an image based question, then there are very good chances of question to be asked as a third ventricle boundary. So that's why this section is very important for you, not just to identify the structure, but just to also remember the boundaries of third ventricle. मुझे roof दिख रहा है, posterior wall, anterior wall, floor, everything third ventricle is visible in this picture. Moreover, the lateral wall of third ventricle is by what, guys? Third ventricle की lateral wall में क्या present है? Well, we have thalamus and we have hypothalamus. Thalamus and hypothalamus are also visible. So just for the writing sake, lateral wall may you have a thalamus and hypothalamus. Thalamus and hypothalamus are forming the lateral wall. So this is what you are going to see in the sagittal section of the brain, right? That's the sagittal section, guys. तो एक सेक्शन तो सर ये हो गया sagittal section जिसमें थर्ड वेंट्रिकल भी कवर हो रहा है हमारा, एंड यू आर लुकिंग एट द डिफरेंट द स्ट्रक्चर्स प्रेजेंट अराउंड इट. फोर्निक्स एक ऐसा टॉपिक है जिसके ऊपर अलग से क्वेश्चन भी आए हुए हैं, सो आई शुड टेल यू लिटिल अबाउट द फोर्निक्स. गाइस, फोर्निक्स स्टार्ट कहाँ पे होता है, एंड कहाँ पर होता है. आई विल शो यू द फोर्निक्स इन द नेक्स्ट सेक्शन ऑल्सो, बट देयर इज अ थिंग अबाउट द फोर्निक्स दैट यू शुड नो अबाउट. गाइस, फोर्निक्स इज अ व्हाइट मैटर बंडल विच इज कनेक्टिंग द हिपोकैम्पस. मान लेते दिस इज हिपोकैम्पस, हिपोकैम्पस जो कि टेम्पोरल लोब में इनर एस्पेक्ट ऑफ टेम्पोरल लोब. सो फोर्निक्स इज अ व्हाइट मैटर बंडल जो हिपोकैम्पस से स्टार्ट होगा, विल गो फॉरवर्ड एंड डाउनवर्ड, एंड अल्टीमेटली दिस फोर्निक्स इज गोइंग टू टर्मिनेट इनटू द मैमिलरी बॉडी. It terminates into the mammillary body. This is MB is mammillary body. This, the structure which I'm highlighting with yellow color, guys, this is fornix. This is the fornix here. तो जो fornix अभी आपने सेक्शन में देखा, that the whole fornix अगर आपको दिखाई दे तो fornix is a white matter bundle. This fornix is a white matter bundle जो कि originate कहाँ पर हो रहा है, हिपोकैम्पस के अंदर. It originates in hippocampus and it terminates in mammillary body. originates in hippocampus and terminates in medullary body. ये क्वेश्चन पहले नीट में भी आ चुका है INICT के अंदर भी कि देव गिवन अ पिक्चर ऑफ द फॉर्निक्स और पूछा है कि ये जो मार्क्ड फाइबर है स्टार्ट कहाँ पर हो रहे हैं. सो मार्क्ड फाइबर वर फॉर्निक्स and they're starting where hippocampus. They've already asked this question कि they're starting where in the hippocampus. Maybe next time ऐसे पूछे where they're terminating in what? Medullary body. So fornix is a white matter bundle जो कि start हो रहा है hippocampus से and it is terminating into the medullary body. Terminates into the medullary body. चलिए. That is one section, guys. The next section that I'm going to show you is the coronal section, and the advantage of the coronal section would be, well, along with this coronal section, हमारा lateral ventricle भी cover हो जाएगा इसमें. Our lateral ventricle will also be covered in this here. So in this coronal section, guys, first of all, where the lateral ventricle? That is where the lateral ventricle is present. Look at that LV over there. And there is a third ventricle which is present here in between. So lateral ventricle and third ventricle. Let me enlarge this picture so that I can show you things more clearly. In the lateral ventricle, the medial wall, मैं पहले medial wall के बारे में बात करता हूँ. The medial wall of the lateral ventricle is by the septum जो corpus callosum में नीचे था, guys, and that was septum pellucidum. So the septum here is the septum pellucidum. That is septum pellucidum, and septum pellucidum is forming the medial wall. In fact, it is the only major structure which is forming the medial wall of the lateral ventricle. Then corpus callosum roof में present है. This is the corpus callosum that is present in the roof. थोड़ा और ऊपर चलते हैं यहाँ पे. That is corpus callosum. Corpus callosum is present in the roof area. So एक मेजर स्ट्रक्चर रूफ में है, that is corpus callosum. एक मेजर स्ट्रक्चर मीडियल वॉल में है, that is septum pellucidum. And rest everything is present in the floor. अब फ्लोर में क्या क्या चीजें present है, guys? If I start with this here, this is the thalamus. Look at that. That is the body of the caudate nucleus, which I am marking here, right? So starting with this, that is the body of the caudate nucleus. Body of the caudate nucleus, that's one. उसके और नीचे जाएंगे तो you will see the thalamus. And then देखो, let's see it this way. अभी मैं जब third ventricle देखा, I want all of you to please pay attention in this, guys. When you saw the third ventricle, बेटा third ventricle roof में क्या था? In the roof of third ventricle fornix था और choroid plexus था. Third ventricle का roof is by fornix and choroid plexus. That means lateral ventricle floor is by fornix and choroid plexus. As you can see in this picture, if this is third ventricle, इसकी रूफ में यहाँ पर आपको दिख रहा है that is what fornix area, and that plexus over there is a choroid plexus. From the lateral ventricle point of view, I can say they are present in the floor. So this fornix और इसके साथ से जो plexus आपको दिख रहा है that is a choroid plexus, ये दोनों आपको कहाँ दिखाई देंगे? फ्लोर के अंदर. So that is the fornix. That's a coronal section of fornix and choroid plexus. Fornix and choroid plexus, well, all these structures are present in the floor. They're all present in the floor of the lateral ventricle. So now again I can see the roof. Roof is just by the corpus callosum. Medial wall is just by the septum pellucidum, and floor is by the caudate nucleus है, thalamus है, fornix and choroid plexus area. Okay. ये तो हुआ फ्रॉम द लैटरल वेंट्रिकल पॉइंट ऑफ व्यू कि लैटरल वेंट्रिकल का रूफ क्या है, मीडियल वॉल क्या है, बाउंड और फ्लोर क्या है. देयर इज नो लैटरल वॉल, गाइस. वी जस्ट हैव रूफ है, मीडियल वॉल है, फ्लोर है, लैटरल वॉल नहीं होता. अच्छा, इफ आई गो लिटिल बियॉन्ड, अगर मैं इसके और आगे देखूं, व्हाट एल्स आई कैन सी, इफ आई सी फर्दर बियॉन्ड, outside this caudate nucleus and this what do you say, thalamus, there is this internal capsule. That's how the internal capsule is going to look like in the coronal section. Internal capsule identification is also one of the image-based question asked to you guys. Not in this section, in the transfer section, but yeah, you should know it in all possible sections. If I go furthermore lateral to the internal capsule, the nucleus present here, this gray matter nuclei guys present here is called what? Lentiform nucleus. Furthermore lateral, that is a lentiform nucleus. This nucleus is a lentiform nucleus. And finally guys, outside the lentiform nucleus, look at this area of the brain which is hidden. ये बाहर से नहीं दिखता आपको. There is hidden inside. It is hiding inside the lateral sulcus. This is called as an insula. Insula or insular cortex. It is a hidden area of the brain. It's a hidden area of the brain, right? So these are the things which जो आपको coronal section में identify करनी guys. That is of boundaries of the lateral ventricle. You can see the roof of the lateral ventricle, medial wall and the floor. And then if I go more outside the lateral ventricle, आपको internal capsule दिखेगा. Furthermore outside you have a lentiform nucleus, and furthermore outside you will see the insula or the insular cortex will be visible to you. Okay, so guys, we talked about this diatal section, we talked about this coronal section, and finally the transverse section as well. So let us take this transverse section. In fact, let me crop this image because section from one side is a little higher. That is not required. Yeah, so let me take this exactly appropriate manner. Now in the transverse section, देखो यार बेटा corpus callosum is supposed to be here. This is the area of the corpus callosum. अगर ये corpus callosum वाला area यहाँ पर, तो the most anterior part of corpus callosum is genu. So आपको genu वाले fiber यहाँ पर दिखाई देंगे. और स्प्लीनियम विल बी समवेयर हियर. स्प्लीनियम वाले फाइबर आपको यहाँ पे दिखाई देंगे. तो कॉर्पस क्लोसम का जीनू एंड स्प्लीनियम. जीनू इज द मोस्ट एंटीरियर पार्ट, स्प्लीनियम इज द मोस्ट पोस्टीरियर पार्ट. नाउ फ्रॉम द जीनू ऑफ द कॉर्पस क्लोसम you can see the fibers which are running forward, the fibers which are going forward. This white matter bundle is called as a forceps minor fiber. और स्प्लीनियम से जो फाइबर पीछे जा रहे हैं, that is called as a forceps major fiber. These are fibers of corpus callosum only. But these fibers of corpus callosum are running like a forceps. They are going forward and backward so that they can connect the frontal lobe and occipital lobe to each other. So this white matter bundle, which is an extension coming from the genu of the corpus callosum, it is called as a forceps minor. Forceps minor are the fibers of corpus callosum जो कि genu से बाहर निकल के आ रहे हैं, forceps minor. And the one which is running from the splenium posteriorly, that is called as the forceps major. Forceps minor and forceps major. Forceps minor and forceps major. And forceps major के अगर आप और भी बाहर जाएंगे, देखो this is the posterior horn of lateral ventricle. Can you see the posterior horn? That's a posterior horn of lateral ventricle. So if you go furthermore outside the posterior horn, there is another set of white matter that you will notice there in the posterior side, and that is called as a tapetum. That is called as a tapetum. See, the point here is, अब तक जो मैंने आपको शो किया पिक्चर के अंदर, that is forceps minor number 1, forceps major number 2 coming from posterior part, and lateral to the posterior horn, this white matter bundle is called as a tapetum. ये पीछे की तरफ tapetum. These are nothing, just the part of corpus callosum. ये कुछ अलग नहीं है, ये corpus callosum के fiber की extension ही है guys. It is an extension of the fibers of corpus callosum only. Forceps major, forceps minor, and tapetum. But the thing which are usually asked to you in the exam is identification of structure inside and about the relations of internal capsule. देखो बेटा इसमें internal capsule कहाँ पर present है? This is the internal capsule. Look at this white matter bundle running like this. That is the internal capsule. ये internal capsule आपको, right? So that is the internal capsule. When we look around the internal capsule, guys, what are the things that are visible to you? The number one, this is the caudate nucleus. It's the head of caudate nucleus now, but let me just simply say caudate nucleus. It's the head of caudate nucleus, or caudate nucleus is there. आपको dorsal side में that you're looking at here, that is the thalamus. So I can say that medial relation of internal capsule is caudate nucleus and thalamus. अगर internal capsule relation पूछते हैं, तो medial relation of the internal capsule is caudate nucleus or head of caudate nucleus and thalamus. जबकि lateral relation is once again the lentiform nucleus. Well, when I saw the question asked to you guys in the exam, it was a lentiform nucleus asked to identify in the transverse section. Lentiform nucleus. And furthermore, once again, this is a hidden cortex which is called as what? Insula. The hidden gyrus or hidden cortex, that is called as insula or the insular cortex. Insula or insular cortex. Yes, perfect. There are two active Ranjans right now in the chat, and you both are correct. So yeah. So guys, the basic principle here is that obviously they can formulate dozens of questions from neuroanatomy, but again we have to go with the trend that एक sectional anatomy question आता है, and the question is asked on the sectional anatomy of the brain, एक या दो, in fact one or sometime two question also. I've seen two question asked in the same paper. So you have to identify the structure, whether it is a transverse section or it is the coronal section or it is a sagittal section. You got to identify the structure. So identify karna. Boundaries of ventricle. Fourth ventricle, though we saw here only, that is dorsal aspect of brainstem is basically showing you the boundary of fourth ventricle. ये fourth ventricle का floor ही है. And the most important thing in the fourth ventricle floor is the facial colliculus. इतना याद रख लो चलेगा. Sagittal section में identify the chest around it, and we are also covering what ventricle here, third ventricle. Coronal section में we are discussing the relations of the internal capsule and everything, and we are also covering what ventricle, lateral ventricle. So हम arbitrarily in section में हमने ventricles भी cover कर लिया. The major thing about the third, lateral and the fourth ventricle are also covered in these sections. Right, so guys, this is something which I want you people to kind of especially pay more attention to when it comes to the neuroanatomy part here. When it comes to the questions in the FMGE examination and the INI-CT, मैं नीट को जरा एक बार हटाता हूँ बीच में से INI-CT examination. There's a big difference in the kind of question being asked. And right now we are focusing on the FMGE examination. So guys, I would say that आपको बहुत ज़्यादा डिटेल में जाने की ज़रूरत नहीं है अभी. If you are able to manage to identify the structures in the different sections of the brain, that is you're good to go with that here. So as I said, you can see the question asked on the identify the internal capsule, identify the lentiform nucleus. ये दोनों question आपके already exam में आ चुका है identification को लेकर. There was a question which is also about in the given section of the sagittal section of the brain, colored region correspond to the paracentral lobule. What structure would be impacted by the lesion in the particular area here? Abhi, knowing about the paracentral lobule, guys, when you look at the brain areas, lateral surface of the brain and medial surface of the brain, कुछ areas हैं जो important है. Not every area is important. We don't have to mark every single area, but there are certain important areas we need to mainly focus on. अब वो important areas कौन से? Let me just point out few of them for you. Yeah. Look, I'm going to go very quickly in this. If you look at the lateral surface of the brain, that is how the lateral surface is going to look like. That's the lateral surface. This is the central sulcus. That is the central sulcus. Abhi central sulcus के आगे we have a precentral gyrus and we have a post-central gyrus. But a precentral gyrus is with this area number 4 is there, and post-central gyrus we have area number 3, 1 and 2. Precentral gyrus, that is area number 4, and post-central gyrus, that is area number 3, 1 and 2. Again, I'm just marking the most important areas, not all of them. Area number 4 and 3, 1 and 2 you already know about. That central sulcus के आगे, this is the motor cortex. This is the area which is the motor cortex. It's a motor cortex. All the motor tract, pyramidal tract or corticospinal tract यहीं से start होगा. That is a motor cortex. Whereas the area which is 3, 1 and 2 present behind the central sulcus, it is a sensory cortex. It's the primary sensory cortex. All the major sensory fibers are ultimately landing into this sensory cortex, right? So let me try to use the same highlighter there. It's a sensory cortex 3, 1 and 2. And the motor cortex is area number 4, which is right in front of the central sulcus. In the inferior frontal gyrus, अगर आप frontal lobe को divide करो, we have superior frontal, middle frontal, inferior frontal. In the inferior frontal gyrus, guys, in the inferior frontal gyrus, this is the area where we have area number 44 and 45. 44 and 45 को सबसे पहली बात तो है कहाँ पर? It is present in the inferior frontal gyrus. 44 and 45, which is present here in the inferior frontal gyrus. Well, what makes this 44, 45 so important? It is the Broca's area, also called as a motor speech area. This area is called as the Broca's area or the motor speech area. अगर इस area में कोई भी injury होगा तो the patient will have a motor aphasia. The Broca's aphasia will be there, motor aphasia will be there in that case. So that is area number 44, 45. Then, well, in the temporal lobe, superior temporal, middle temporal, inferior temporal. In the superior temporal gyrus, we have this area present here, that is area number 41 and 42. 41 and 42 की importance क्या है? 41, 42 is the primary auditory cortex. It is primary auditory area or the primary auditory cortex, that is 41 and 42. 41, 42, that is a primary auditory cortex. And surrounding the area number 41 and 42 is area number 22. देखो यहीं पर ही आपको मिलेगा. Just around 41, 42. This area is area number 22. And More posteriorly, you will see two more areas, that is area number 39 and 40. 40 is above, 39 is below, 39 and 40. So this 39, 40 and 22 also, guys, 22 को साथ में काउंट करना है यहाँ पर. देखो, let me highlight this for you. 22, 39 and 40. 39 and 40 which are present more toward the posterior part of temporal lobe. All these areas collectively are the component of Wernicke's area. हमने Broca's area देखा, अभी हम देख रहे हैं Wernicke's area, guys. That is a Wernicke's area. 22, 13 and 40 collectively, that is a Wernicke's area. And any injury to the Wernicke's area, that will lead to the sensory aphasia. That type of aphasia will be the sensory aphasia, guys. That will be the sensory aphasia. That will be sensory aphasia in that case. Right, so ये कुछ important areas हैं which are to be noticed from the lateral surface. So if you get an image based question, you should be able to identify कि especially Wernicke's area और Broca's area कहाँ पर present है. Motor sensory cortex is also important, but from the question point of view, it's the Wernicke's and the Broca's area that is very, very important. Now, when you look at the medial surface of the brain, guys, this is how it is going to look like. Sagittal section देख रहे हैं, and that's how the medial surface is going to look like. This is corpus callosum, and there is a medial surface of the cerebral hemisphere. Now there is a sulcus that you will see present above the corpus callosum running like this, called a cingulate sulcus, and this cingulate sulcus divides into two limbs like this. This sulcus here is a cingulate sulcus. Cingulate sulcus, and you can see cingulate sulcus is dividing into two limbs, and between the two limbs of cingulate sulcus you will see a very small projection of central sulcus also. देखो वैसे तो central sulcus कहाँ होता है? Lateral surface पे, but there is a small projection of central sulcus on the medial surface as well, and this area which is surrounding the central sulcus, जिसके ऊपर question पूछा भी है in the recent time, is called as a paracentral lobule. Paracentral lobule. What makes the paracentral lobule such an important area? First of all, paracentral lobule is present on what surface? Medial surface. So lower limb का representation होता है यहाँ पर. Upper limb, hand and face especially, these areas are present on the lateral surface. When I say sensory cortex and motor cortex, like motor cortex is area number 312, this is sensory, motor cortex is 4 and sensory cortex is 3, 1 and 2. Representation of the face, representation of the hand is in this area. यहाँ पर हैंड और फेस वाले एरियाज होते हैं, यानी कि हैंड मूवमेंट कंट्रोलमेंट, फेशियल मसल कॉन्ट्रैक्ट और द सेंसेशन फ्रॉम द हैंड एंड फेस विल कम इन टू दिस एरिया. बट व्हेन इट कम्स टू द लोअर लिम इज रिप्रेजेंटेड ऑन व्हाट साइड? मीडियल साइड. सो पैरासेंट्रल लोब्यूल, एक तो पैरासेंट्रल लोब्यूल की इंपॉर्टेंस क्या है कि इट इज अ लोअर लिम्ब एरिया, whether it's a sensation from lower limb or it is a motor control of the lower limb, both paracentral lobule. And secondly, paracentral lobule is important because it is the highest center. It is the highest center for micturition and defecation. It's the highest center for micturition and defecation. So अगर patient को paracentral lobule वाले area में injury होगा तो lower limb paralysis होगा उसको, lower limb muscle will get affected, lower limb sensory loss will be there, and also there is a loss of bladder control and the rectal control will be there. Micturition and defecation control centers are also there in the parasite. It's the highest center for the micturition and defecation. Finally, one more thing that I need to tell you guys, there is a sulcus present here called as a calcarine sulcus. This sulcus is called as a calcarine sulcus. And the importance of calcarine sulcus is that visual cortex is present around it here. So we have area number 17. 17 के बाहर आपको मिलेगा 18 और 18 के बाहर आपको मिलेगा 19. So it's more like this. It's present around it. So area number 17, we got 18, and furthermore outside we got area number 19. 17, 18, 19. This is area number 17 is the primary visual cortex or the primary visual area. It's the primary visual cortex. जबकि 18 and 19 are the visual association area. These are called as a visual association area. They connect the visual input to the previous memory, guys. That is the visual association areas are there. So again, I have to just cut short onto the important part here. These are the important areas that you should know present on the medial surface. One is the paracentral lobule here and the visual cortex of calcarine sulcus के around present. Let's say 17, 18, 19. That's a primary visual area and the visual association area is with there. And lateral surface के ऊपर ये सारे areas guys, especially Broca's area and Wernicke's area. Overall, I mean from the current examination trend point of view, again FMG exam हो, NEET exam हो, अगर मुझे most important areas यहाँ बोलने तो Broca's, Wernicke's and paracentral lobule. इन तीनों पे जरा नजर रखना because there are very good chances of getting a question on that. So guys, this is few things that I've decided to discuss in the neuro part. This was a question asked in the exam. मैं एक बार question पे लेके चलता हूँ आपको. Though you'll be discussing these questions with Dr. Nikhil. So in these given section of the brain, the colored region corresponds to the paracentral lobule. What structure would be impacted by the lesion of this particular part? और ऑप्शन के अंदर लोअर लिम्ब दिया हुआ था गाइस. तो अगर पैरासेंट्रल लॉब्यूल में इंजरी होगा तो आइदर ब्लैडर कंट्रोल, बाउल कंट्रोल में इशू होगा, और इट विल बी अ लोअर लिम्ब इशू विल बी देयर. लोअर लिम्ब मसल्स और लोअर लिम्ब सेंसरी लॉस विल बी सीन बिकॉज पैरासेंट्रल लॉब्यूल इज ऑन व्हाट सरफेस? मीडियल सरफेस, और लोअर लिम्ब वाला एरिया यहाँ पर. Okay. चलिए सर, with that let us now start with the next portion. हम थोड़ा सा डिस्कशन करेंगे on some of the topics of the embryology as well. अभी I know embryology is something that usually has been a headache for most of us. Embryology में बहुत ज़्यादा डिटेल में नहीं जाएंगे. Embryology में जो mainly question पूछते हैं, again there's a question which is asked about the pharyngeal arches एंड डायफ्राम. लाइक अगर मुझे पूरी एम्ब्रियोलॉजी के अंदर सबसे जो दो मेजर टॉपिक है जो मेनली एम्फेसाइज करना, वन इज अ डायफ्राम डेवलपमेंट जिस पे क्वेश्चन मल्टीपल टाइम आया हुआ है, एंड फेरेंजियल आर्चेस गाइस, ब्रेंकियल सिस्ट, क्लेफ्ट ऑन पाउचेस की क्या क्या डेरिवेटिव्स हैं, तो उनके ऊपर क्वेश्चन आता है. सो आई वुड से एम्ब्रियोलॉजी के अंदर इन योर रिविजन प्लान कीप देम एज अ प्रायोरिटी टॉपिक. लाइक और भी चीज़ें हैं बट कीप देम एज अ प्रायोरिटी टॉपिक. दो मैं आपके साथ फेरेंजियल आर्च आर्टरीज भी डिस्कस करूंगा बिकॉज देयर इज अ क्वेश्चन आस्क्ड इन द रीसेंट टाइम ऑन द डक्टस डिफरेंस ऑल्सो. Okay, thanks अभिनंदन. So guys, let us start with देखो एक क्वेश्चन आया है इसमें, एक्स्ट्रा एम्ब्रियोनिक मीजोनम इज डिराइव्ड फ्रॉम. बेटा एक्स्ट्रा एम्ब्रियोनिक मीजोनम क्या होता है? इट्स अ मीजोनम आउटसाइड द एम्ब्रियो, जो एमनियोटिक कैविटी के बाहर और योग से के बाहर एक्स्ट्रा एम्ब्रियोनिक मीजोनम होता है. इसके क्वेश्चन को मैं इसलिए बोल रहा हूँ यहाँ पर बिकॉज इसका आंसर कुछ बुक्स में गलत दिया हुआ है और पुराना कोई आंसर दिया हुआ है. इफ द क्वेश्चन इज आस्क्ड एक्स्ट्रा एम्ब्रियोनिक मीजोनम इज डिराइव्ड फ्रॉम वेयर, योर आंसर इज द प्राइमरी योग सैक. At some places the trophoblast आंसर दिया होगा, वो नहीं चलेगा. Primary yolk sac guys, you got to go with the latest text in that. Primary yolk sac is the right answer. Primary yolk sac will give rise to extra embryonic mesonym. Primary yolk sac with extra embryonic mesonym. देखो मैं आपको पहले एक पिक्चर शो करता हूँ. The picture of the embryo, like obviously we are not going into detail of the entire embryology. How this image will look like जब आपको न्यूरल ट्यूब, नोटोकॉर्ड, मीजोडर्म, एंडोडर्म, एक्टोडर्म सब कुछ दिखाई देगा when you look at all those things together, and then there could be a question कि what is giving rise to what, right? So एक पिक्चर के अंदर हम ये काफ़ी कुछ कवर करेंगे यहाँ पर. So I want all of you to pay attention to this one guys. See, I'm showing you the picture of approximately third week का end हो गया. third week का end of the third week का embryo अगर आपको देखो तो the image is going to look something like this, that there will be एक्टोडर्म, इसी एक्टोडर्म से बनेगा न्यूरल ट्यूब, और एक्टोडर्म के और न्यूरल ट्यूब के जंक्शन पे आपको यहाँ पे स्पेशल सेल्स दिखाई देंगे. दीज आर द न्यूरल क्रेस्ट सेल्स. न्यूरल ट्यूब का डेवलपमेंट जो हुआ है, इट इज डन बाय द स्ट्रक्चर और इट इज इन्फ्लुएंस्ड बाय द स्ट्रक्चर कॉल्ड एज अ नोटोकॉर्ड, जो न्यूरल ट्यूब के नीचे मिलेगा आपको. दिस विल बी एंडोडर्म, और ये जो पूरा हाईलाइटेड एरिया में येलो कलर यूज कर रहा हूं, दैट इज फॉर द मीजोरम. ये पूरा मीजोरम गाइस, दिस होल थिंग इज मीजोरम. यू कैन सी इवन द न्यूरल ट्यूब इज सबमर्जिंग इटसेल्फ इनटू द मीजोरम ओनली. या एक्टोडर्म, दिस इज एंडोडर्म, and then mesoderm will divide into further part. I'll come to that. पहले इसको मार्क कर लेते हैं. These cells guys, these are what cells? These are the neural crest cells. This is neural tube, and this is notochord. Obviously notochord is something which will influence the formation of nervous system. बिना नोटोकॉर्ड के नर्वस सिस्टम नहीं बनेगा. नोटोकॉर्ड इज द वन which stimulates the ectoderm, और उसी ectoderm से फिर आपका न्यूरल ट्यूब बनता है. That is in notochord. Now, when you're looking at the picture where ectoderm, mesoderm, endoderm, everything is visible to you, you are looking at the notochord. आपको mesoderm भी दिखाई देगा dividing in three parts, guys. Mesoderm divides in three parts. Like one part of the mesoderm is the para-axial mesoderm. Then we have intermediate mesoderm, and then we have lateral plate mesoderm. Lateral plate mesoderm. दोनों साइड पे होगा. Obviously, I'm just drawing on one side only, guys. There is a para-axial. It is just next to the axis, so we call it a para-axial mesoderm. Immediate next to that, we got a mesoderm which is called as the intermediate mesoderm. In बीच में है तो in नाम ही intermediate. That is intermediate mesoderm. And third, we got a lateral plate mesoderm. Lateral plate, paraxial, intermediate, and lateral plate mesoderm. Okay, just one second, guys. Don't go anywhere. It's not a break. Don't go anywhere. Just give me 1 minute. Okay, sorry for that interruption. So guys, what I was saying that you're looking at the neural tube, you're looking at notochord, the neural crest cells, ectoderm, endoderm और mesoderm का को 3 पार्ट दिखाई देंगे. Now this is a picture जो कि नीट एग्जाम के अंदर इन द लास्ट ये क्वेश्चन ऑलरेडी इमेज 2 बार आ चुकी है. इन द रिसेंट टाइम, इन द लास्ट 3 years ओनली, दिस क्वेश्चन इज आस्क्ड ट्वाइस इन द नीट एग्जाम. सो मुझे बहुत स्ट्रांगली लगता है कि ये इन FMG दिस क्वेश्चन इज बाउंड टू बी आस्क्ड. देखो नीट वाले क्वेश्चन ही बाद में फॉर्मुलेट करके FMG पूछते हैं. इनफैक्ट वाइस वर्सा ऑल्सो सम FMG क्वेश्चंस आर आस्क्ड इन नीट एग्जाम. सो जनरली वी से यू शुड बी अवेयर ऑफ, इवन द FMG पीपल शुड बी अवेयर ऑफ कि नीट में क्या क्वेश्चन चल रहे हैं, बिकॉज there are very good chances of getting the question around the same area in your exam as well. And given that in the last couple of FMG examination, the level of questions are like it's a par level to the NEET exam, so we definitely can expect the questions asked, kind of question asked in NEET in the FMG exam also. So the question here is कि what are the derivatives of the neural tube, neural crest cells, paraxial, intermediate, lateral plate mesoderm. देखो इसको बहुत सिंपल लेके चलते हैं. There are other details which are inquired in it. मैं PDF के अंदर वो include भी कर दूंगा. वो I'll put that snapshot of neural crest cell derivatives, neural tube derivative. But हम इसको let's take it in a very simplest way. If it is about the derivatives, देखो it goes like this. Neural tube. The neural tube is all about central nervous system. So when you think about the derivatives of neural tube, आपको सिर्फ CNS और डेरिवेटिव के बारे में सोचना है. CNS मतलब brain, spinal cord, even the glia cells. When you talk about the ependyma, when you talk about the astrocytes, when you talk about the oligodendrocytes, anything which is doing the myelination for CNS, which is a lining epithelium of ventricle, any glia cell, अगर वो central nervous system का part है, तो it is derived from where? Neural tube. Neural tube, the key word is central nervous system. Central nervous system. Neural crest cell, peripheral nervous system. Anything and everything about peripheral nervous system is derived from neural crest cell here. Rather than remembering आप ये 30-40 structures के list को याद रखोगे तो neural crest cell सीधी सी बात है यार. The entire peripheral nervous system is formed by the neural crest cell. अब कोई भी nerve हो, any enteric plexus, any ganglion guys, sympathetic chain हो, parasympathetic ganglion हो, sympathetic ganglion हो, dorsal root ganglia, whatever it is, OT ganglion, any ganglion, जहाँ पे word ganglion आ जाए समझ जाओ it is derived from where? Neural crest cell. Schwann cells, because Schwann cells do the myelination for what? Peripheral nerves here. So the moment you see anything which is pertaining to the peripheral nervous system, it is derived from where? Neural crest cells. So one easy way, either you will get the right answer or at least you will be eliminate the wrong answer if you do that here. So the moment you think of neural tube derivatives, आपको सिर्फ central nervous system सोचना है. Don't go outside the CNS. When you think of neural crest cell, you only think about peripheral nervous system. आपको CNS के बारे में नहीं सोचना. Now you have to think about the nerves coming out, nerves of pharyngeal arches, anywhere, any nerve in the body, plexus, enteric plexus like orbex plexus, myenteric plexus, any ganglion like otic ganglion, sympathetic ganglion or parasympathetic ganglion, all of them are derived from where? Neural crest cell here. So neural tube, central nervous system, and neural crest cell is all about peripheral nervous system. Notochord का काम क्या था? Notochord, the job of notochord was to stimulate the development of nervous system, guys. It starts the nervous system formation. It is not forming the neural tube. The job of notochord is to stimulate the formation of nervous system here. हालांकि notochord का हमारे पास खाली बाद में एक remnant मिलेगा आपको. I'm writing NC for notochord. Notochord का एक remnant, guys. A major remnant notochord which can be asked to you is something called as a nucleus pulposus. Nucleus pulposus. It's a central part of intervertebral disc. That nucleus pulposus जो कि intervertebral disc के अंदर होता है, it is a remnant of the notochord. Right? It is a remnant of notochord. अब आते हैं सर para-axial, intermediate and lateral plate mesoderm के ऊपर. So if I may take it this way, देखो para-axial. Guys, paraxial mesoderm, there will be thickening of the paraxial mesoderm, and that thickening of the paraxial mesoderm will give rise to what? Somites. Thickening of the paraxial mesoderm will give rise to somites. और somites के derivatives होते हैं. Somites will give rise to number one, to the dermis of back. पीछे dermis of back बनेगा उससे, number one. Number two, it will give rise to the axial skeleton. Axial skeleton, ribs हैं, sternum है, vertebral column है, like axial. जो midline का आपका skeleton है, axial skeleton is by this somites, which is basically paraxial mesoderm only. And number three, it will also give rise to what muscle? Skeletal muscles. It will give rise to skeletal muscle, right? This is the paraxial mesoderm, which will give rise to somites. Somites are thickening of the paraxial mesoderm. तो आपको दोनों साइड में मिलेंगे, न्यूरल ट्यूब के दोनों साइड पे you will see condensation, that is called as somites, and that will give rise to dermis of the back, axial skeleton and skeletal muscle. अब क्वेश्चन ये है कि whatever is not derived from paraxial mesoderm is derived from where? Lateral plate mesoderm. Lateral plate, guys, lateral plate mesoderm will give rise to everything which is not derived from the paraxial mesoderm or somites. अब वो क्या होगा? That means this will give rise to the dermis of front. This will give rise to the dermis of the front, number one. This will also give rise to the front and limbs, dermis of front and limbs. This will give rise to the appendicular skeleton. Upper limb and lower limb की bones, guys. जितनी भी upper limb और lower limb की bones होती हैं, they develop from the lateral plate mesoderm only. And finally, this will give rise to the smooth and cardiac muscle also. Smooth muscles and cardiac muscle. Comparative रखना है. Just keep it comparative. Paraxial mesoderm और lateral plate mesoderm बड़े comparative हैं. Whatever is derived from paraxial mesoderm, अगर आपको ये मालूम है, तो automatically you know what is derived from lateral plate mesoderm. Whatever is not derived from paraxial mesoderm will come from lateral plate mesoderm. तो guys बचा क्या? Intermediate, बीच वाला. Intermediate mesoderm. And intermediate mesoderm is something which will give rise to the urogenital system. It will contribute to the formation of the urogenital system. Mesonephric duct, paramesonephric duct, testis, ovary, जो सब यहाँ से बनने वाला है. Intermediate mesoderm will take care of that here. Yes, Ranjan, you're right. I'm not going into the somatopluric and splanchnopluric. I don't think they will be asking the somato and splanchnopluric layer, different part of the, because lateral plate mesoderm भी divide हो जाता है somato splanchno में. Again, you have to like focus on that what is exam oriented. paraxial mesoderm, lateral plate mesoderm, and intermediate mesoderm. They're overall derivatives, and I'm sure that you'll get the answer from here itself. So guys, देखो अगर आप ये इतना भी ध्यान रखोगे ना, तो I'm sure that you will still able to get the answer to this question here. Neural tube, neural crest, derivatives, notochord का remnant क्या है, and the three part of mesoderm, paraxial, intermediate, lateral plate mesoderm, and what are their overall derivatives. I'm pretty sure that you still will be able to get the right answer if you know this much also. चलिए, ये तो हुआ regarding this about the tube part here. There was a question asked about a newborn is present with a congenital defect shown in the given picture. Actually, anencephaly का image दिया हुआ guys, head develop नहीं हुआ ठीक से. That is a picture given of the anencephaly, and it was which type of embryological defect is that. Basically देखो इस question में आप एक चीज ध्यान रखिएगा कि cranial neuropore, जब न्यूरल ट्यूब, आप अभी न्यूरल ट्यूब देख रहे थे, दैट यू जस्ट सॉ द न्यूरल ट्यूब हियर. दिस न्यूरल ट्यूब नीड टू क्लोज ऑन द क्रेनियल एंड आल्सो, एंड न्यूरल ट्यूब नीड टू क्लोज ऑन द कॉर्डल एंड आल्सो. एक क्रेनियल न्यूरोपोर है और एक कॉर्डल न्यूरोपोर है. सो वन इज अ क्रेनियल न्यूरोपोर, लेट मी जस्ट राइट हियर, एंड अनदर थिंग देयर इज अ कॉर्डल न्यूरोपोर. cranial and the caudal neuropore. But a cranial neuropore, it closes on day 25. अब 25th डे पर ये cranial neuropore बंद हो जाता है ideally. और caudal neuropore is the one which closes on day 28. ये 28th डे पर बंद हो जाता है. Cranial neuropore closes on day 25. Caudal neuropore closes on day 20. बेटा cranial is एक ही बात है. Cranial neuropore को आप anterior neuropore भी बोल सकते हैं, याद रखिए. Cranial neuropore is also called as an anterior neuropore. Caudal neuropore is also called as a posterior neuropore. एक ही बात है, cranial और anterior. Caudal neuropore is posterior neuropore. अब क्वेश्चन ये है कि cranial neuropore अगर क्लोज नहीं हुआ, if it fails to close, अगर वो फेल हो गया, then it will give rise to the anencephaly. Anencephaly is because of the failure of closure of the cranial neuropore. Similarly, अगर caudal neuropore close नहीं हुआ, if there is a failure of closure of caudal neuropore, then it will give rise to the spina bifida. Then the condition could be the spina bifida. The spina bifida. Right, so this is this. अगर आपको न्यूरल ट्यूब के बारे में क्वेश्चन पूछना है, you can already see the neural tube in the picture here. न्यूरल ट्यूब आगे से बंद होगा, पीछे से बंद होगा. एंटीरियर न्यूरोपोर, पोस्टीरियर न्यूरोपोर. एंटीरियर न्यूरोपोर 25th डे पर बंद होता है और पोस्टीरियर न्यूरोपोर जो बंद होता है वो 28th डे पर. पॉइंट ये, अगर बंद ना हो तो, इफ द क्रेनियल और द एंटीरियर न्यूरोपोर विल नॉट क्लोज, एनेंसेफेली. इफ पोस्टीरियर और द कॉर्डल न्यूरोपोर क्लोज नहीं होगा, तो दैट विल गिव राइज टू स्पाइना बाइफिडा. ओके, मैं एक और क्वेश्चन लेता हूं, उसके बाद में फेरेंजियल आर्चेस पर आता हूं लास्टली. देखो गाइस, during the examination of a newborn in nursery, the doctor noticed that meconium is coming out of the umbilicus. Which of the following is most likely the cause? Now ये question इसलिए important है because there is a picture of the folding of the embryo. Craniocaudal folding हो रहा है, embryo का craniocaudal folding is taking place. और craniocaudal folding of embryo के अंदर आपको ये notice करना है कि that what are the things of the yolk sacs which will come out. Look, what I'm saying is, okay. See, when you look at the picture of the craniocaudal folding, guys, let us say here is an image of the folding of embryo taking place. So it's a craniocaudal folding. मान लेते हैं अगर इधर कहीं, this is the head side of the embryo, and then you have the tail side of the embryo. Yes, beta. Life of Soheb, open neural tube defect. Exactly, open neural tube defect is there. देखो क्वेश्चंस एग्जैक्टली क्वेश्चन क्या थे, एमसीक्यू क्या थे, ऑप्शंस क्या थे, वो आप नेक्स्ट सेशन में करने वाले हो, राइट. डॉक्टर निखिल के साथ आप करोगे एमसीक्यू डिस्कशन. मेरा पार्ट जो है कि मैं इन क्वेश्चंस के अराउंड जो टॉपिक उनको थोड़ा सा डिटेल में डिस्कस कर लूँ आपके साथ, सो दैट जब आप वो क्वेश्चन करेंगे तो यू शुड बी एबल टू गिव द बेटर आंसर फ्रॉम योर साइड, राइट. बट यू व्हाट यू इफ द ऑप्शन ओपन न्यूरल ट्यूब डिफेक्ट वाज गिवन, दैट एब्सोल्युटली इज द राइट आंसर. Now let us say this is the umbilical cord. ये आपको embryo folding दिख रही है और there is the umbilical cord here. Here is the yolk sac, guys. जब embryonic folding होगी तो सब कुछ fold होगा. Neural tube, notochord, ectoderm, mesoderm, endoderm सब कुछ fold होगा ना. And during that folding taking place, you will see that there is a folding of the yolk sac also. Now look at this. The yolk sac is being folded, and there is one part of the yolk sac that you see squeezing inside the umbilical cord called as a vitellointestinal duct. And there is another part of the yolk sac which is extending into the umbilical cord that is called as the allantois. That is the allantois. Like, so this is basically the yolk sac जिससे हमारा gut बनेगा, foregut, midgut, hindgut. That is the yolk sac. And look at the two extensions of the yolk sac, guys. The one which is coming from the tail toward the tail side of the embryo, this is called as the allantois. And the another extension that you see, which is actually coming from the yolk sac, this big duct here is called as a vitellointestinal duct. That duct is a vitellointestinal duct. Yeah, omphalomesenteric duct also. Exactly. You can also call it a omphalomesenteric duct also. एक ही बात है. अब देखो बेटा, allantois और vitellointestinal का fate क्या है यहाँ पर? बेटा, allantois जो है caudal part पे present है. This will get obliterated and will form urachus, and this will ultimately form a ligament of the bladder which is called as a median umbilical ligament. Median umbilical ligament. Median umbilical ligament is a ultimate resultant. Allantois बंद हो जाएगा, that will form a urachus, and urachus will form a ligament of the bladder called as a median umbilical ligament. ये तो normal situation है, जब ये बंद हो जाएगा. Abnormal condition क्या है कि allantois अगर बंद नहीं हो, अगर allantois patent रहेगा. If allantois is patent, then what you will see, it will form a direct connection of the urinary bladder to the umbilicus, and that is urinary fistula. There will be urinary fistula, guys. Obviously, if it is patent, so instead of forming the median umbilical ligament, it is directly communicating the bladder to the umbilicus, that is a urinary fistula. So urine can be seen coming out of the umbilical opening. इस केस में अगर allantois patent रह गया, if allantois is patent, तो urine droplets can be seen coming out of the umbilical opening. But हमारा question urine droplet के ऊपर नहीं, meconium के ऊपर है. The meconium discharge can be seen coming out of the umbilicus. वो किस वजह से? Vitellointestinal duct, guys. Vitellointestinal duct generally vitellointestinal duct का remnant, it could be Meckel's diverticulum. Meckel's diverticulum could be the remnant of the vitellointestinal. One of the most common anomaly of the midgut development is a Meckel's diverticulum presence. लेकिन अगर again guys, if the entire vitellointestinal duct is patent, अगर ये पूरा vitellointestinal duct patent रह गया, in that case it is going to form the fecal fistula. It is going to form the fecal fistula. Then fecal material, the meconium, can be seen coming out of the umbilical, discharging from the umbilicus here. So दोनों पे क्वेश्चन पूछ सकते हैं, allantois के ऊपर, vitellointestinal duct के ऊपर. Vitellointestinal duct अगर पेटेंट रह गया तो that can lead to the fecal fistula. Meconium can be seen coming out of the umbilical opening. अगर allantois पेटेंट रह गया पूरा तो it can lead to the urinary fistula. ये urine droplets can be seen coming out of the umbilicus here. उन्होंने already question पूछ लिया vitellointestinal duct के ऊपर. They might ask you the question on the allantois also. So be prepared for that as well. Okay. So this is about the craniocaudal folding, guys. This was one of the question asked, and let me lastly tell you about देखो इसमें ना I don't know आपका जब you have a next session which is the question. My main target here is to look into the major topics like head and neck, neuroanatomy, embryology, and then इसके बाद मैं एक limbs का session भी लूँगा आपके लिए, and the rest of the things वो questions में cover हो जाएगी आपको. Don't worry about that here. Now the two main things on which the questions are very frequently asked is one, diaphragm development, and even more important is the pharyngeal arches and pharyngeal arch arteries. So let's talk about these two more topics from the embryology, the core embryology, जहाँ से question आने के सबसे ज़्यादा chances हैं. So guys, let's go into the first. Let me talk about the diaphragm here. Now, in the development of the diaphragm, what you're going to see, if this is the picture of a developing diaphragm, let's say if this is a vertebral column, so what you'll see, diaphragm development, there are four things which are required. Number one, there is something called as the dorsal mesentery of esophagus. अगर image based question भी आए तो you should be able to identify them. That's how you're going to see it. This is the dorsal mesentery of esophagus. Dorsal mesentery of esophagus. Developmentally, dorsal mesentery of esophagus, it gives rise to the crus of the diaphragm. The right crus and the left crus of the diaphragm. Right and the left crus of the diaphragms are derived from the dorsal mesentery of esophagus. Then another structure that you will see contributing heavily in the diaphragm is something present developmentally. ये पहले आगे present होता है, बाद में center में चला जाएगा. That is septum transversum. The second thing which is required here is a septum transversum, guys. Septum transversum. And the septum transversum is known for giving rise to the central tendon of the diaphragm. Central tendon of diaphragm बनेगा septum transversum से, which is nothing but the lateral plate mesoderm only. That is septum transversum. We also have something present toward the lateral side, posterior lateral side, guys. What is that toward the posterior lateral side? This is the body wall mesoderm. Body wall mesoderm, कुछ जगह पे इसको cervical somites पे लिखा होगा, एक ही बात है, body wall mesoderm और somites, cervical somites. Now this body wall mesoderm or cervical somite, which is seen more toward the posterior lateral side initially, this is going to give rise to the muscular part of diaphragm. Muscles of diaphragm will come from here only. The muscular part, the muscles of the diaphragm will mainly come from this portion. और इन सब के बीच में there is something left in between them. There is a membrane, there is a thin membrane left in between them. This membrane is called as a pleuroperitoneal membrane. This membrane is pleuroperitoneal, guys. This membrane is called as a pleuroperitoneal membrane. Well, होता क्या है, generally this pleuroperitoneal membrane is covered with muscles only. The muscles which will be coming from here will be covering this pleuroperitoneal membrane. पहली बात तो guys, it is a pleuroperitoneal membrane and not pleuropericardial. आपको ऑप्शन में प्लूरोपेरिटोनियल मिलेगा और प्लूरोपेरिकार्डियल भी मिलेगा, तो याद रखिएगा इट्स प्लूरोपेरिटोनियल एंड नॉट पेरिकार्डियल. नाउ प्लूरोपेरिटोनियल मेम्ब्रेन इज जनरली कवर्ड बाय मसल ओनली. प्रॉब्लम सर ये है कि अगर मान लो प्लूरोपेरिटोनियल मेम्ब्रेन इफ इट इज एब्सेंट, अगर प्लूरोपेरिटोनियल मेम्ब्रेन एब्सेंट ही होगा, वेल इन दैट केस इट विल लीड टू द कंजेनाइटल diaphragmatic hernia, the Bogdale's hernia. The congenital diaphragmatic hernia is because of the absence of what membrane? Pleuroperitoneal membrane. It is because of the absence of this membrane called as a pleuroperitoneal membrane. Pleuroperitoneal membrane. Right, so this is about the diaphragm. कि इमेज बेस्ड क्वेश्चन पूछें या नॉन इमेज बेस्ड क्वेश्चन पूछें, यू शुड नो कि डॉर्सल मेसेंटेरी ऑफ एसोफेगस से क्या बनेगा, बॉडी वॉल मेसोडर्म क्या बनाएगा, सेप्टम ट्रांसवर्सम से क्या, और प्लूरोपेरिटोनियल मेम्ब्रेन if it is present, fine, it will be covered by muscle only later on, but अगर प्लूरोपेरिटोनियल मेम्ब्रेन ही एब्सेंट है तो that will give rise to the diaphragmatic hernia, the congenital diaphragmatic hernia. नहीं बेटा, यूरोरेक्टल फिस्टुला अलग होगा. यूरोरेक्टल फिस्टुला में तो यूरिनरी ब्लैडर इज कम्युनिकेटिंग विद रेक्टम. देखो होता है कि यूरिनरी ब्लैडर और रेक्टम दोनों एक ही चीज से बनते हैं, क्लोएका से, राइट. क्लोएका इज गोइंग टू फॉर्म द रेक्टम ऑल्सो, क्लोएका इज गोइंग टू फॉर्म द यूरिनरी ब्लैडर ऑल्सो. अगर क्लोएका पूरी तरह डिवाइड नहीं होगा, इफ द क्लोएका इज नॉट डिवाइडेड कंप्लीटली, then in that case there is a fistula found between the rectum and the urinary bladder, that is called as urorectal fistula. वो अलग है. यहाँ पे जो ओपनिंग प्रेजेंट है वो अम्बिलिकस के साथ है, अम्बिलिकल ओपनिंग के साथ है, नॉट विद ईच अदर. Okay, so this was about the diaphragm. चलो finally let me take you to the pharyngeal arch. देखो pharyngeal arches and pharyngeal arch arteries दोनों ही important है. और pharyngeal arches के अंदर, if I tell you very quickly, pharyngeal arch में भी first arch, second arch, third arch, fourth and the sixth arch is there. Fifth तो होता ही नहीं है. So in the pharyngeal arches, देखो सेकंड pharyngeal arch की स्पेशलिटी क्या है गाइस? दैट्स द फर्स्ट आर्च. सेकंड pharyngeal arch की ओवरग्रोथ होती है लाइक दिस एंड इट इज गोइंग टू कवर अप अदर pharyngeal arches फ्रॉम इनसाइड लाइक दैट. दैट्स अ सेकंड आर्च ectoderm, थर्ड आर्च, फोर्थ आर्च एंड सिक्स्थ आर्च. सेकंड, थर्ड, फोर्थ एंड द सिक्स्थ. So this one is the first arch, this one is second. Here we have third pharyngeal arch, the fourth arch and the sixth pharyngeal arch. और आप पिक्चर में देख भी पा रहे हैं कि second pharyngeal arch का ectoderm is growing out and down. This ectoderm of the second pharyngeal arch is growing downward and outward, and that is basically covering up other pharyngeal arches from outside. देखो, this space that you have, which is formed by the ectoderm growth of the second pharyngeal arch, this is called as a cervical sinus. This is called a cervical sinus. Eventually cervical sinus बाद में बंद हो जाता है, but in some cases the cervical sinus, it may persist, and if the cervical sinus persists, that will give rise to the swelling present along the anterior border of sternocleidomastoid, called as what? It is called as a branchial cyst. So branchial cyst is nothing, it's a persistence of the cervical sinus. ये cervical sinus जो बन रहा है, ये generally बंद हो जाता है. This cervical sinus usually closes, but if it fails to close, it will give rise to the branchial cyst. हाँ, अगर आपसे पूछते हैं कि branchial cyst is mainly made up of which cleft? देखो guys, this is second cleft, third cleft, fourth cleft, first तो बाहर है. So generally 80 to 85% cases हैं कि आपका जो branchial cyst बनेगा, it is by the second cleft here. Branchial cyst is generally made of the second cleft. Second. It can be made up of the third cleft or the fourth cleft also, or combined all of them also. That is also possible. But usually जो branchial cyst बनता है, those branchial cysts are mainly the remnant of the second cleft. वो सबसे common. 80-85% cases में it is like second cleft remnant part of the cervical sinus will give rise to the branchial cyst. What about the first cleft? ये अकेला cleft है जो बचा. There is a first cleft. बाकी second cleft, third cleft, fourth cleft सब बंद हो गए. First cleft is the only cleft remains, and that is going to give rise to the external auditory canal and outer layer of tympanic membrane. देखो आप head and neck को अगर side से देखो, the only opening that you see on the side of the head and neck ear ही तो है. Side में तो ear ही होता है खाली. और cleft भी हमारे पास एक ही है. In the entire pharyngeal arches we only have one cleft which remains, that is the first cleft, and that is going to give rise to what? External auditory canal. External auditory canal, and it will also give rise to the outer layer of tympanic membrane. Outer layer of tympanic membrane. That is the derivative of the first pharyngeal cleft. एक ही cleft है और उसके derivative हो गए. But when it comes to pouches, guys, pouches तो सारे हैं आपके पास. That is the first pouch. This is the first pouch. Now what first pouch will give rise to? First pouch will give rise to the inner layer of tympanic membrane. It will give rise to the inner layer of tympanic membrane. Middle ear cavity. Auditory tube or eustachian tube. And mastoid antrum. Inner layer of tympanic membrane, middle ear cavity, auditory tube and mastoid antrum. Like सब कुछ अंदर की तरफ वाला. External auditory canal and outer layer of tympanic बाहर की तरफ है guys. They are formed by the ectoderm. That is formed by the first cleft. Pouches are all endodermal. Pouches सारे endodermal हैं. Cleft और ectodermal होते हैं. And pouches will give, first pouch will give rise to the inner layer of tympanic membrane. In continuity with the inner layer of tympanic membrane is a middle ear cavity. Of it, though extension guys, auditory tube in front and mastoid antrum posteriorly, they are also made up of the first pouch only. Second pouch will give rise to the palatine tonsil. Third pouch, very important guys, third pouch will give rise to the thymus. And along with the thymus, it will give rise to the inferior parathyroid gland. Inferior parathyroid gland. Why inferior? Because superior parathyroid gland will come from fourth pouch. Superior parathyroid gland will be derived from the fourth pouch. Inferior parathyroid gland is from the... So the reason the third pouch is important, because that's yet another question asked in the recent time exam. No, FMGE mein nahi, but in the NEET PG. But again, you should know about this. That third pouch, thymus and inferior parathyroid. So any anomaly of the third pouch, guys, agar iski anomaly hongi, like you must have read this in the DiGeorge syndrome, the patient will have an absent thymus. The patient with the absent thymus and hypoparathyroidism. Hypoparathyroidism, that is because of the anomaly of third pouch. What they did is उन्होंने क्वेश्चन दिया, एक ऐसे एक हैंड ड्रॉन टाइप का पिक्चर ही था फेरेंजियल आर्चेस का, और उसमें पूछा हुआ था कि अ पेशेंट विद द एब्सेंट थाइमस एंड हाइपोपैराथायरॉयडिज्म इज बिकॉज ऑफ एनोमली ऑफ विच ऑफ द फॉलोइंग. तो आपको थर्ड पाउच मार्क करना था. थर्ड पाउच एनोमली कैन लीड टू व्हाट? एब्सेंट थाइमस एंड हाइपोपैराथायरॉयडिज्म. दैट इज अबाउट थर्ड पाउच. डी जॉर्ज सिंड्रोम, एग्जैक्टली दैट इज अ डी जॉर्ज सिंड्रोम. चलो, so guys, that is about the cleft and pouches. Cleft में कुछ है नहीं बेटा, फर्स्ट क्लेफ्ट एक ही क्लेफ्ट है हमारे पास, बाकी तो सब बंद होगी बिकॉज ऑफ सर्वाइकल साइनस. Pouches first, second, third, fourth, all the pouches are there between these respective pharyngeal arches. And finally, one last thing that I'm going to tell you here in the development is about the pharyngeal arch arteries. Which pharyngeal arch artery will give rise to what? Because it's again a very straightforward and repeatedly asked question about the pharyngeal arch arteries and the development, guys. Look, to understand the pharyngeal arch arteries and their derivatives, बेटा वॉल्यूम मेरा फुल है यार, यहाँ से बेचा मैं वॉल्यूम इससे ज़्यादा नहीं हो सकता मेरा. I can just pull the mic a little more close to me, but the mic volume is full from my side. Maybe the volume is a little less only from my end. You can just please increase the volume from your end if you can. Okay, pharyngeal arch arteries का, pharyngeal arch arteries के लिए इसको ऐसे देखते हैं. There are two dorsal aorta. यहाँ पर एक right dorsal aorta है यहाँ पर ऐसे, and there is this left dorsal aorta. There initially embryo के पास दो aorta हैं, एक right and the left dorsal aorta. This is the right dorsal aorta, and this one here is the left dorsal aorta. Right and the left dorsal aorta. Then what you'll see that there is this the cranial end of the heart tube. Heart tube का जो cranial end होता है, there is a truncus arteriosus. फिर उस ट्रंकस आर्टरी से निकलता है aortic sac, and aortic sac will divide into the right horn and the left horn of the aortic sac like this. This is, I'm writing AS, that is aortic sac. AS is for the aortic sac, और उसके दो horn दिख रहा है आपको, right horn and left horn of aortic sac. And this right and left horn of aortic sac, they're connected to the dorsal aorta by 6 pharyngeal arch arteries. It's first arch artery, second arch artery, the third, the fourth, fifth, and the sixth. Fourth and the sixth here. But I'm speaking in English only. In between I'm talking in Hindi because the people are asking me the question in Hindi, so that's why I'm trying to respond in the Hindi as well. Okay, let me just keep it all English now. So we have the 6 pharyngeal arch arteries on the left side, and similarly we have the 6 pharyngeal arch arteries on the right side. 3, 4, 5, and the 6th. Now that's the beginning of this. In the development, guys, you will see that there is an aortic sac. There are 2 horns of aortic sac, and there are 6 pharyngeal arch arteries coming from them and connected to dorsal aorta. Now the question here is that what arch artery? बहुत डिटेल में नहीं जाना. We don't have to go into too much of detail. We just need to know that which arch artery will give rise to what main artery out of here. Now the main artery, let me point out here, that is the arch of aorta. Arch of aorta is by the 4th arch artery, guys. Just forget about aortic sac, right horn, left horn. You don't need that here. You just need to know arch of aorta if the question is asked where it is coming from. So arch of aorta is mainly developing from where? From the left 4th arch artery. Left side 4th arch artery. Left 4th arch artery. Okay. Now arch of aorta is giving multiple branches. Like for example, there is a brachiocephalic artery. Guys, look at the what I'm highlighting here. That is a brachiocephalic artery. Right? That is brachiocephalic. So I can say that brachiocephalic artery is simply by the right horn. I'm writing RH. Right horn of aortic sac. Right horn of aortic sac. Okay. Another branch from the arch of aorta I'm using different color to show them so that there will be no confusion. Like, look at this. That's a common carotid and internal carotid artery, guys. Third arch artery will give rise to common carotid and internal carotid. External carotid artery will just come out as a bud only. And you have the same story on the right side also. This time it is coming from brachiocephalic. But I can say third arch artery will give rise to common carotid and internal carotid. Basically, the proximal part of this artery will give rise to the common carotid artery. And the distal part will give rise to the internal carotid. And this bud is for external carotid. That's a bud for the EC. External carotid artery bud is there. So if the question is asked on the third arch artery, third arch artery is the one which will give rise to the common carotid artery and internal carotid artery. Even external carotid artery also, but external carotid artery is simply coming out as a bud only. Then what you'll see that on the left side, the subclavian artery is directly coming from the arch of aorta, guys. There is an artery, a subclavian artery is simply found by something called as a left 7th cervical intersegmental artery. Left 7th cervical intersegmental artery, and left 7th cervical intersegmental artery will give rise to the left subclavian artery. So left subclavian artery is not a problem. Left subclavian artery is directly coming from one of the segmental artery called as 7th cervical intersegmental artery. This dorsal aorta, guys, it is having multiple segmental arteries. We have 1, 2, 3, 4, 5, 6, 7. Then we have T1, T2, T3, T4, T5, thoracic segmental artery. So 7th cervical segmental artery will give rise to the subclavian artery of the left side. No problem. What about right side? Now on the right side also we have the 7th cervical intersegmental artery. No problem with that. We do have right 7th cervical intersegmental artery, but that alone will not give rise to subclavian artery, because subclavian artery on this side, the subclavian artery on the right side, we need 4th arch artery also. We need 4th arch artery. So if the question is asked about the formation of the right subclavian artery, the story is different, guys. Right subclavian artery is found by, number one, it is by the right 4th arch artery. It is by the right 4th arch artery, plus it is by the right 7th cervical intersegmental artery. Right subclavian artery. What difference है? In the left subclavian artery, it is just by the 7th cervical intersegmental artery. That's it. But for the right side, this whole thing is a subclavian artery. This whole thing is subclavian artery. So I need 4th arch artery also. So right side 4th arch artery and the right 7th cervical intersegmental will give rise to this. When the lungs will start to develop, lung buds, LB, when the lungs will start to develop, you will see that 6th arch artery is going to invade the lung buds. 6th arch artery, guys, lung buds के अंदर चला जाएगा. 6th arch artery will go inside the lung bud. So I can say that pulmonary artery, okay, this is important. Pulmonary artery is derived from, it is derived from the proximal part of 6th arch artery. Proximal part. Only the proximal part of 6th arch artery will give rise to the pulmonary artery. Proximal part of 6th arch artery will give rise to the pulmonary artery. And finally, look at this one, guys. This is ductus arteriosus. जो आपसे question पूछा exam में, the question which is asked to you in the exam is about this. That is ductus arteriosus. I'm writing DA. Ductus. So whether it is normal ductus arteriosus or patent ductus arteriosus is because of what? It is because of the, it is found by the distal part of the left. It's important, left, guys. Left 6th arch artery. Distal part. Distal part of left 6th arch artery is going to give rise to the ductus arteriosus, and that actually was the question asked in the exam. There is a question asked in the exam here. Ductus arteriosus is by the distal part of the left 6th arch artery. Even the people with a patent ductus arteriosus. So if the distal part of the left 6th arch artery persists even after birth, that will give rise to patent ductus arteriosus. Patent ductus arteriosus. Guys, fifth arch though anyways will disappear. So 5th arch will disappear, so nothing of the 5th arch will be there. But 1st and 2nd arches will have some remnants. So overall, if you see, we have some remnant of 1st arch artery, remnant of 2nd arch artery. I'll tell you what remnant are those. 3rd arch artery is giving rise to common carotid, internal carotid. Fourth arch artery on the left side forms the arch of aorta, but on the right side forms a subclavian artery. And sixth arch artery will give rise to pulmonary artery and ductus arteriosus. So it could be it is one of the match the following question asked in the NEET exam. It very well can be asked in the FMG sector also. So guys, the question is about these arteries and match the following. Like the first arch on one side, if I'm writing the arch, and on the other side, if I tell you what arteries are derived from it, arch and the respective arteries. First arch, remnant of the first arch is the maxillary artery. Maxillary artery is a remnant of first arch artery. Second arch, stapedial and hyoid. Stapedial artery and hyoid artery is the remnant of second arch artery. Remnant, guys. These are remnants only. Third arch we saw clearly. Third arch will give rise to what? Common carotid artery as well as internal carotid. You can even say external carotid also, but common carotid, internal carotid main. Fourth arch artery on the left side is forming the arch of aorta. On the left side forms the arch of aorta, and on the right side forms the right subclavian artery. It forms the right subclavian artery. And sixth arch artery, it will give rise to the pulmonary artery and ductus arteriosus. That is ductus arteriosus. Ductus arteriosus. Charubala, my dear, applied, the reason I'm not discussing the applied part of it, because you understand the pharyngeal arch and their development. And again, as I said, again, you have a session coming up. So the question discussed over there, I'm sure that will be covering up this portion here. But just to tell you, the main thing is that the first arch, and when it comes to anomaly, the first arch anomaly is a craniocaudal dysostosis. The main thing that you need to know, that the mandible, the zygoma, this malar prominence will not be developed completely, because first arch will give rise to mandible, maxilla, and all the zygomatic bone. That's why the first arch disorder is there. So first arch anomaly, it's a craniocaudal dysostosis, which is the main thing that you need to remember. Rest of the arch arteries is important. Rather than the component of what arches are giving rise to, arch arteries are what giving rise to is more important in the rest of the pharyngeal arches. So this is about the pharyngeal arch arteries, pharyngeal arch and their arch arteries, what they're giving rise to, guys. In the recent time, there's a question asked on the ductus arteriosus. So whether it's a ductus arteriosus or a patent ductus arteriosus, it is by the remnant of the distal part of the left sixth arch artery. Right, left, zarur yaad rakhega. It's a distal part of left sixth arch artery which is giving rise to the ductus arteriosus, the patent ductus arteriosus mainly. Okay. Basically, guys, what we are basically covering up this whole thing in the conjunction, like few things covered in the more in the theory discussion I'm doing here, and there are certain things which will be covered up with the question discussion which we'll be doing in the next session with Dr. Nikhil as well. KP beta, ये सब होगा. देखो the subcostal plane, the transpyloric plane which is at the lower border of L1. Yeah, I know that these questions are there, but no, these questions again, they can be discussed with the question itself here. That's what I'm saying. Your next part you're discussing is the question with Dr. Nikhil, and he's discussing all these PYQs only with you. And in this PYQs, I know that this question is asked, subcostal plane is asked, sternal angle is asked, transpyloric plane is asked. That will be covered there only. Don't worry about it. Chalo guys, so this is I would say this is a portion of embryology, must do portion of embryology. Obviously embryology is way beyond this what we have discussed here, but I would say this is something that you have to kind of keep an eye on, especially diaphragm development. I would say this picture is important, and I'm saying this picture is important keeping the NEET exam in mind, because NEET is asking this question over and over again. So there are very, very good chances of getting a question on the embryo where you get this the question about the allantois and the vitreointestinal duct. And the most important thing is the pharyngeal arches. More you read about pharyngeal arches, you will there's no disadvantage in doing that. In the embryology, I would say for the FMG examination point of view, keep the pharyngeal arches as your top priority to read, right? Chalo sir, with that note, let's take another break. It's already more than 2 hours for this session. So let's take another break, guys, and we'll take a break of around half an hour, right? Let's take a 30 minutes break. We'll come back and I'll have one more session with you But this time the session is only about the limbs. So upper limb, lower limb, mainly the muscular part. Again, nerve and nerve injuries, that we'll mainly going to pay attention to that part. And after my session, then you have Dr. Nikhil's session. Rest of the portion, like some of the questions of the pyloric plane and all that, and some of the viscera question will be covered. The topics will be covered along with the questions only, right? Chal, I'll see you in 30 minutes, and then we'll continue with our part and we'll discuss the limbs, upper limb and lower limb, in the next session.